Are you able to hear now? I think you should be able to hear now because initially I think I didn't switch on the audio. Right now I switched it on, so I think it must be all good. Yeah. Hi guys. Hi everyone. Hi everyone. Hi everyone. Happy Saturday. Yeah. Thank you so much for all your patience. As usual, it's a Saturday evening, so my OPD got a little busy. So it got a little late. So that's the reason why we have rescheduled the session by approximately around 20-25 minutes. So nothing to worry. So we are good to go. So let us start with the cardiology questions and the relevant explanations. Cool. All right. So let us start the session. So let us move into the first question. So here the first question over here. So which of the following markers in this patient is most likely to be increased? Okay, in the first few minutes of the onset of chest pain and back to the baseline within 12 hours. So what they're asking is which marker rises within the first few minutes, okay, after the onset of chest pain, and which marker comes back to the baseline within 12 hours. So that is the question over here. So is it CKMB, that is creatine kinase of the heart specific fraction, or B option is HFABP, that is heart type fatty acid binding protein, and C option is IMA, that is ischemia modified albumin, and option D is troponin I. So what do you think is the right answer? So you need to have a good understanding about different cardiac markers. Okay, it's a very common question, isn't it, as far as exams are concerned? So, okay, I'm getting plenty of answers. Somebody is telling option A, some people are saying option B, somebody is saying option C, some people are saying D, troponin I. I couldn't believe that. Okay, nevertheless, so let us see some important data with regards to the cardiac markers. So let me write a small table over here. So I'm writing the biomarker, and then I'm going to write the onset of initial rise, then the time where the serum levels are going to peak up, and when they return back to baseline. Return to baseline. Return in the sense we are talking about return to baseline. Okay, all right. So the first marker is CKMB. One of the old markers, we don't use it anymore. So when it starts rising within 3 to 4 hours. It reaches a peak in approximately around 24 hours. But the most important point here is the fact that it's going to come back to baseline in 40 to 78 hours. I'll repeat, it's going to come back to baseline in 40 to 78 hours. That is the reason why it's been proposed as a probable marker of reinfarction. In your basic textbooks like biochemistry, they would have mentioned it as a probable marker of reinfarction. But right now, we don't use CKMB, practically speaking, as a marker of reinfarction. Also, we are going to use only troponins no matter what. So what about cardiac troponin T, and what about cardiac troponin I? So if they ask you which is the best marker is always cardiac troponins. There is no doubt about that. Among the troponin T versus troponin I, what you're going to choose in exams, go for troponin I, because in many trials it's been proved that troponins are considered to be specific and sensitive. Apart from that, the troponin I is relatively more specific compared to that of troponin T. So that's why in exams, maybe you can consider troponin I. That's it. But otherwise, in reality, whether you use troponin T or whether you use troponin I, it doesn't make any much big difference at all. So when does the troponin rise? Troponin tends to rise within 2 to 4 hours. Whether it's troponin T or I, it's going to rise within 2 to 4 hours. And it's going to reach a peak level in 24 to 48 hours, which is highly variable. Okay, which is highly variable. Sometimes it can reach a peak level within 12 hours also, in case if you are reperfusing the patient. If you are not reperfusing, then it reaches a peak level in 24 to 48 hours. And then if it's going to be troponin T, it comes back to baseline in 10 to 14 days. If it's going to be troponin I, it comes back to baseline within 7 to 10 days. Okay, so this is a very, very important point. So when it comes back to baseline, troponin T 10 to 14 days, troponin I, it is 7 to 10 days. So these are the only biomarkers that we need to know as far as practicality is concerned. But what are the theoretical markers? We have something called HFABP. That's called heart type fatty acid binding protein. It tends to start rising within 1 to 1.5 hours, and it reaches a peak within 4 to 6 hours, and it comes back to baseline within 24 hours. That's a very important point. And what about myoglobin? There's another marker called as myoglobin. So Dr. T.N. Medquench is asking, are you working at Mehta? Yes, I'm working at Dr. Mehta's hospital. I am the head of the department of internal medicine there. And I'm not only heading internal medicine department, I'm also heading the department of infectious diseases. And my specialty areas are going to be rheumatology and infectious diseases. That is what I specialized in, basically. So these are not basically PYQs. These are modified PYQs, I would say. But the most important topics are the ones that we're going to cover in these sessions. So what about the onset? So myoglobin is going to start rising within 1 to 4 hours. It's going to reach a peak level in 6 to 12 hours, and it's going to come back to baseline within 24 hours. Okay, so that's true about myoglobin as well. So what about your IMA? So finally, we have something called IMA. This is called as ischemia modified albumin. I'll repeat, this is called as ischemia modified albumin. Ischemia modified albumin. So it starts to rise within minutes. Okay, it's been proposed as one of the excellent markers to improve the sensitivity of diagnosis of acute coronary syndrome. But nevertheless, I would say that it starts rising within minutes, and it reaches a peak level within 6 hours, and it's going to come back to baseline within 12 hours. Okay, so that's a very important point as well. So among all the markers which I've told, you can clearly see that the ischemia modified albumin is the one that's going to come back to baseline within 12 hours, and it's going to rise within minutes. So it's clearly given in our question that which marker rises within the first few minutes and comes back to baseline within the first 12 hours. So what will be your answer now? So very simple, your answer is going to be IMA. That is going to be ischemia modified albumin. That's it, nothing more than that. So because CKMB is not going to rise in the first few minutes, it's going to take approximately around 3 to 4 hours. What about HFABP? It's not going to rise within the first few minutes. It's going to take around 1 to 4 hours at least. And what about your troponin I? Troponin I also is going to take around 1 to 4 hours. I mean, troponin I is going to take around 2 to 4 hours to start rising. So it's not going to rise within minutes. And coming back to baseline also, CKMB is going to come back to baseline only in 48 to 72 hours. Your HFAB is going to come back to baseline within 20 to 24 hours. And troponin I is going to come back to baseline within 7 to 10 days. Okay, so the right answer for this question is going to be ischemia modified albumin, IMA. So let us see some other important properties of the cardiac marker. So it's not just about knowing the onset of rise and the peak serum level and when it comes back to baseline. You need to also know about the important curves with regards to the cardiac biomarkers. So what will be the rate of rise of cardiac biomarkers and what will be the rate of fall in a patient with any myocardial injury? So why we use biomarkers? So remember, when we are talking about biomarkers are basically markers of cardiac injury. So we are not talking about ACS, or we are not talking about myocarditis, or we are not talking about any specific disease. We are talking about cardiac injury. So anything that causes cardiac injury, you are going to see rise in the biomarkers. So which is going to be sensitive and specific for cardiac injury? Remember, I'm not using the term which is sensitive and specific for MI. And I'm not using the term which is sensitive and specific for acute coronary syndrome. I'm using the term which is sensitive and specific for cardiac injury. The answer for that is going to be, so somebody is asking about LDH. Yes, LDH is an outdated marker. I'll come back to that. So which is sensitive and specific for cardiac injury? It is the troponins. So that is the reason why we stick to troponins. Remember, CKMB is neither sensitive nor specific. Let it be any other marker. They are neither sensitive nor specific. Troponins are the ones that are going to be the most sensitive and the most specific for cardiac injury. Okay, we are not talking about ACS or MI. That's a very important point. So when will you call the patient is having a myocardial infarction? There is something called universal definition of MI. So simply, if you want to call it as myocardial infarction, things are going to be very simple. It should be an acute myocardial injury, number one. It should be an acute myocardial injury. And that should be due to ischemia. Then only you are going to call it as myocardial infarction. I'll repeat, it should be an acute myocardial injury and that should be due to ischemia. That's it, nothing more than that. So how will you say that the patient is having myocardial injury? Whenever there is increase in cardiac biomarkers. Increase in cardiac biomarkers, I can say that the patient is having myocardial injury. That is the reason why I have to use a specific biomarker and a sensitive biomarker to pick up the injury earlier. At the same time, I should be sure that the injury is in the heart only, not anywhere else in the body. That is the reason why I am going to use troponins for that. Either T or I, but I is what you have to answer in exams. But mortality wise, there is no difference whether you use T or I. Doesn't matter. So now you know what is myocardial injury. How will you say it's an acute myocardial injury? Point number 2. For that only, the dynamics of troponin is going to be very, very useful. So what is going to be the dynamics? So look at this. So your cardiac biomarkers, any biomarker for that matter, is going to follow this curve. Okay, this is how it's going to be, which means it's going to start rising initially. It's going to reach a peak level and then it's going to come back to the baseline. So this is the dynamics during any acute myocardial injury. As simple as that. So it will take its own sweet time to be detected. That is what we call as onset of rise. It's going to take some time to reach a peak value and it's going to come back to the baseline over a period of time. So this rise and fall, okay, I'll repeat, this rise and fall of the cardiac biomarkers is what is going to be suggestive of acute myocardial injury. So rise and fall of cardiac biomarkers, okay, is what we are going to call it as acute myocardial injury. So that is the reason why in the universal definition of myocardial infarction, they would have given rise and fall, okay, of cardiac biomarkers. It's not just increase in cardiac biomarkers, it's rise and fall. That's going to tell you that it is an acute myocardial injury. Remember, if the biomarkers are raised, but it is stable, it's not changing that much. So it's raised, but it's just stable. It is not changing that much. Then you're going to call it as chronic myocardial injury. Chronic myocardial injury. I'll repeat, if the biomarkers are raised, but it is not changing. Okay, there is no rise and fall pattern. It is stable, but it is raised. Okay, we're going to call it as chronic myocardial injury. So in practice, we need to have a cutoff. How much it should rise from one value to another value, or how much change should happen between one value and another value. So generally, if you are going to use any biomarker, let us assume commonest and the most frequently used biomarker is going to be cardiac troponin. If you're using a cardiac troponin, you're going to take a troponin, let us assume at the time of admission. And then you're going to repeat cardiac troponin after a period of 3 to 6 hours. Okay, generally we do that. After 3 to 6 hours, we are going to repeat. And how much change should happen to say it is an acute myocardial injury, and how much change should be there to say it's a chronic myocardial injury. So if the change, okay, if the rise and fall, or probably what are the rise or the fall, the change is more than 20%, I can say it's an acute myocardial injury, because in acute myocardial injury, it is dynamic. It's going to be changing. It's going to rise and fall. There will be changes. It will not be stable. Okay. The troponin will not be in the steady state. That is why change by more than 20%. Acute myocardial injury. The same thing you will study in AKA also. AKA, what you study? Creatinine. Okay, that's the marker of acute kidney injury. Okay, in myocardial injury, it is troponin. That's the only difference. You will see the similar definition in AKA also. Change in creatinine, increase in creatinine by 0.3 milligrams per deciliter, or increase in creatinine by 50% compared to the baseline. See, all these injury markers will be dynamic in acute setting. In chronic setting, it will be stable. Okay, it's not going to change that much. So that's why whenever the change in the troponin is more than 20%, you're going to call it as acute myocardial injury. If the change in troponin is less than 20%, you're going to call it as chronic myocardial injury. The change is less than 20%, you're going to call it as chronic myocardial injury. So instead of using the rise and fall of troponins or rise and fall of markers, you can even use this term, okay? Change more than 20%, you can call it as acute myocardial injury between two cardiac troponin values, which are taken at least 3 to 6 hours apart. So now you know what you mean by the term acute myocardial injury. That alone will not tell you that it is MI, because even myocarditis can cause acute myocardial injury. Somebody has stabbed in your heart, that can cause acute myocardial injury. So we have to prove that it is due to ischemia. How will you prove that it is due to ischemia? That is why they have given a separate criteria. Point number 1, patient should have ischemic chest pain. I think every one of you will be knowing what do you mean by ischemic chest pain. Okay, how the ischemic chest pain will be there. So clinical. Second, you can pick up with ECG also. If you are proving that the patient is having new STT changes, the patient is having new ST segment T wave changes. new ST elevation, ST depression, T wave inversion, some new dynamic changes, or new pathological Q waves. Remember, whenever there are pathological Q waves, it indicates that the myocardium is dead, it's infarcted. So new pathological Q waves. So that will tell you it's actually due to ischemia. And third, imaging. Imaging. So what are you going to do in imaging? You can do 2D echocardiogram, commonest imaging that you do. Okay. So where you are going to see a new regional wall motion abnormality. That's called RWMA, new regional wall motion abnormality. Why RWMA? Because if the area is ischemic, that area is not going to contract properly. That is what we call it as RWMA, regional wall motion abnormality. For example, if I am having a LAD occlusion, left antidescending artery occlusion, my anterior or anteroseptal wall will not contract properly compared to the other areas. In echo, I can find it out. That is new regional wall motion abnormality. Or I can use other imaging modalities. Okay, like any imaging modality. So I can do maybe CT scan if you want. I can do probably a SPECT scan, or I can see that in cardiac MRI. So whatever imaging, PET CT, so whatever imaging you do, if you see new regional wall motion abnormality, that is referred to as that is a new RWMA. That is going to be one of the criteria for diagnosing MI, myocardial infarction. And similarly, in other imaging technologies, if you prove that there is new loss of viable myocardium, okay, already the myocardium was viable, but new loss of viable myocardium, okay, that is also a sign of ischemia, and that will also be included under the criteria of myocardial infarction. Then finally, in autopsy, if you are going to prove that the patient is having a new coronary artery thrombus, okay, you are seeing a new thrombus in the coronary vessel. So that is also going to tell you that it is a myocardial infarction. So this will be used only in patients who have died all of a sudden. So there are differences in autopsy that you can make between a fresh thrombus and an old thrombus, and using those criteria you can say like whether the patient has got a fresh MI because of that he has died or not. So in autopsy studies also you can prove. So okay, so this is the criteria. So what you have to prove? You have to prove that the patient is having acute myocardial injury, and you have to prove that it is due to ischemia. How will you prove acute myocardial injury? Through rise and fall of cardiac markers, or change in cardiac markers by at least 20% from the baseline value that is taken after 3 to 6 hours. And you know what are the criteria to say it is ischemia. So this is equivalent to myocardial infarction. This is equal to MI. That's all. What are the types of MI? So even that is a very important question in exam. So what are the types of MI? Type 1 MI is there. Type 1 MI is the most common form of MI. That's called as spontaneous MI. Usually it is due to coronary artery disease. That's it. So what do you mean by type 2 MI? Type 2 MI means the patient will get an MI, but it is not due to coronary artery disease, which means it is due to demand-supply mismatch. I'll repeat, it is due to demand-supply mismatch. So what are the examples of demand-supply mismatch? Severe left ventricular hypertrophy, where the supply may be normal, but the demand of the left ventricle is more. Or in patients with severe anemia, where the supply is less, even though the demand is normal, the supply is very less because of severe anemia. So this is what we call it as demand-supply mismatch. Usually this occurs in patients who are in critical care settings, in ICU, or using high-dose vasopressors, inotropic agents, where the demand will be more, but the supply may be less. Okay, but here remember, it is not due to plaque rupture. It is not due to coronary artery disease. Patients may or may not have underlying coronary artery disease, but the plaque rupture is not the reason for type 2 myocardial infarction. It is due to demand-supply mismatch. So technically speaking, type 1 MI means it will be usually due to plaque rupture or plaque erosion. In that, if they ask you which is more common, the answer is going to be plaque rupture. That is more common compared to that of plaque erosion. Plaque erosion is only 1/3. Plaque rupture is going to be the reason for 2/3 of the type 1 MI. So what about type 3 MI? Type 3 MI is the one that kills the patient. So MI causing sudden death will be coming under type 3 MI. What is type 4 MI? It is post PCI or peri-PCI related MI. So I can simply write as PCI related MI. After doing a PCI, if you get an MI, that is PCI related MI. In that you have two types. One is called as 4A and 4B. What is 4A MI? Type 4A means the patients are having peri-PCI MI. I'll repeat, peri-PCI MI. So what is peri-PCI MI? After doing a PCI, within the first 48 hours, if you get MI, that is called as peri-PCI MI. The reason for this is not very clearly known, and the significance of this is also not very much established in practice. But there is a definition for that. Within 48 hours of PCI, we call it as peri-PCI MI. So what about type 4B? It's called as in-stent thrombosis, okay? instant thrombosis, which means if the stent has undergone thrombosis, we call it as type 4B myocardial infarction. So remember, instant thrombosis can occur anytime, which means it can occur immediately, okay, when the stent is being placed in the cath lab itself, or it can occur years later, like after 5 years or even 10 years. So anytime it can occur. There's no timeline for that. And what about type 5? Type 5 is called as post-CABG related MI. That is called as post-coronary artery bypass grafting related myocardial infarction. So in that, there are two criteria they will ask you. Remember, if you want to diagnose a peri-PCA MI, type 4A MI, your troponin value should be more than 5 times the upper reference limit at least. That value is very, very important. For type 4B, it's the routine criteria. There is nothing like that. But for type 4A MI alone, your troponin should be at least more than 5 times the upper reference limit. And for diagnosing a post-CABG, coronary artery bypass grafting related MI, the troponin should be at least more than 10 times the upper reference limit, okay? More than 10 times the upper reference limit. So these are the two important numbers that you need to know. Type 4A, more than 5 times the upper reference limit, and for post-CABG related MI, it should be more than 10 times the upper reference limit. Okay, these are the 5 important types of myocardial infarction, universal types of MI. So now you know that in a patient with acute coronary syndrome, so whenever a patient is suffering from ACS, you can have 2 different types of ACS. One is going to be ST segment elevation acute coronary syndrome, which is also called as STEMI, and the second one is called as non-ST segment elevation acute coronary syndrome, which is going to be further subdivided into N-STEMI and unstable angina. Right now, there is no point in differentiating between N-STEMI and unstable angina because both have the same treatment. There is no difference in the treatment. So basically, what is the problem in ACS? The problem in ACS is plaque rupture. Okay, plaque is getting ruptured, or there is a plaque erosion. Okay, plaque erosion, and this is causing a thrombus. This is a new thrombus. Remember, already there is a disease in the vessel, and the patient is stable. Now there is a new occlusion because of the thrombus formation. Because of platelet activation and clot, new thrombus is getting formed, and that is causing a new dynamic ischemia, new ischemia. And that thrombus is causing the ischemia. Okay, thrombus is causing the ischemia. And that is the reason why you develop ACS in the first place, myocardial injury in the first place. That's why the patient is getting decompensated, because it's an acute event, new ischemia, because of new thrombus buildup, and that is causing the problem. So now what is the difference between a STEMI and a N-STEMI unstable angina? Basically, you all know that ST elevation, okay, is what you're going to see in the ECG if it's a STEMI. If it's a NST ACS, you don't see ST elevation. That's all. That is what you need to know. So don't say ST depression TY inversion. Even though in textbooks they would have given ST depression TY inversion is very commonly seen in NST ACS, but don't say that. No ST elevation. And another important point, if you want to know, how long the ST elevation should be there to say that it's a STEMI. It's not just like 2 minutes or 1 minute of ST elevation. That becomes a transient ST elevation. You cannot call it as a STEMI. To say it's a STEMI, the patient should have at least ST elevation for more than 20 minutes, which means only if the ST elevation is persistent for more than 20 minutes, then only you can call it as STEMI. Otherwise, you cannot call it as STEMI. Even if it's a transient ST elevation, you should be calling it as NST ACS only. Or it should be some other disease like Prince metal angina. So to call it as a STEMI, there should be an ST elevation that should be persistent for at least more than 20 minutes. Here, there won't be ST segment elevation, which means ECG can be normal. Okay, completely normal, or they can have ST depression, or they can have TY inversion, or combination of ST depression, TY inversion, or even transient ST elevation sometimes. Okay, so that is where you're going to call it as NST ACS, or non-ST segment elevation acute coronary syndrome, N-STEMI unstable angina. And what will be the cardiac biomarkers? Remember, troponins will be definitely elevated. Okay, in STEMI, there is no doubt about that, because the injury is very severe here. Whereas in NST ACS, troponin can be normal or it can be elevated. Troponin can be normal or it can be elevated. So I will say that according to the traditional definitions, if troponins are normal, you are going to call it as unstable angina. If troponins are elevated, you are going to call it as N-STEMI. That's all. But in the current era, because we are trying to use high sensitivity cardiac troponins, it's very difficult to get a ACS with a normal troponin. It's very, very unlikely in the current era. That is the reason why the diagnosis of unstable angina itself is getting outdated. It's very difficult to diagnose unstable angina, even though in exams, even now, they are asking unstable angina very commonly. But in practice, diagnosis of unstable angina is very, very rare. We don't do it because you are using high sensitivity cardiac troponins, which are very, very sensitive, which can pick up even small, minute changes in the troponins. Okay, fine. So these are the basic differences. But what are the pathological differences between STEMI and STEMI unstable angina? So first of all, STEMI is due to a full occlusion, which means there is a state of no flow, which means there is absolutely no flow in the coronary vessel. No flow. It's a state of no flow. Whereas NST-ACS, there is an occlusion, there is a thrombus, but some flow is occurring. So it's a state of some flow. Some flow is still there in the vessel. It's not a state of no flow. And most of the time, STEMI will be very, very acute, and the patients with STEMI will have lesser comorbids relatively compared to NSTEMI unstable angina patients, lesser comorbid status. And NST-ACS will be more subacute in nature, okay, and the patients will have plenty of comorbids compared to that of STEMI patients. Okay. So somebody is asking about a doubt, a small query. You mentioned regarding 20-minute duration for diagnosis of ST-ACS. What about the golden period, sir, for this emergency? So remember, we don't wait, okay, to start the therapy. So the moment you see a patient with chest pain, ST elevation, if it's ischemic, troponins elevated, you're going to diagnose as STEMI. Don't wait for 20 minutes to confirm it's a STEMI or not. Okay. You're going to start treatment like a STEMI only. But if the ST elevations are reversed completely within 20 minutes, then probably you can think, okay, fine, on the way. You're not going to start like major treatment like coronary angiogram and PCI within like 20 minutes, right? So it's going to take time. So later on you can diagnose, but initial triad should be like STEMI only. If you see a patient with ST elevation, chest pain and troponin elevation, that is STEMI, that's all. Later on, maybe you can, on the way, you can diagnose something else. So less comorbids, and in NST-ACS patients, you're going to have more comorbids compared to STEMI patients. And also remember that the culprit vessel will be usually only one in a patient with STEMI. I'm not saying patient will have disease only in one vessel. Patient may have disease in multiple vessels. But the one that is causing the STEMI will be a single vessel. That's what I'm trying to mean. The culprit artery will be only one. But NST-ACS, NSTEMI unstable angina, is usually a multi-vessel problem. Okay, it's a multi-vessel disease. So put all these things together. Acute problem. Because it's an acute problem, patients are going to have less collateral supply. Okay, less collateral. Most of the time, NST-ACS is a chronic disease. So you're going to have more collateral flow, improved collaterals. So put all these things together. Acute event. One vessel fully gone. No collaterals. So you're going to have a focal, okay, a focal transmural ischemia. A focal transmural ischemia. That's a very, very important word. Focal transmural ischemia. I'll repeat, focal transmural ischemia. What about NST-ACS? In NST-ACS, you're going to have multi-vessel. Okay? And it's a subacute disease with plenty of collaterals. So you're going to have a multifocal disease. Multifocal disease. And subendocardial, because it's not a complete occlusion. Only flow is affected partially. Some flow is still there. So you know the most vulnerable portion in the myocardium is subendocardial region. So subendocardial ischemia. Subendocardial ischemia. Okay. So multifocal subendocardial ischemia. So that is what is going to occur in a patient with NST-ACS. And what will be the plate? I mean, what will be the type of clot? The clot will be more of fibrin. Okay, fibrin clot, because it's acute, fresh, more of fibrin. But it will be platelet clot. Okay, this is based on autopsy studies. You cannot, prove this in reality, in practice, but this based on autopsy studies. The clot will be made of more of fibrin, fresh clot. That's why it's called as red clot. Whereas platelet-based clots are basically white. Okay, white clot. And that is also the reason why fibrinolysis is going to be very effective in a patient with STEMI, but it's not going to be effective in a patient with NSTEMI unstable angina because it's not made of fibrin. Rather, it's a white clot, platelet clot. Right? So what will be the goal in ST-ACS? Goal in STEMI, the goal of therapy. So what is the goal of therapy? The goal of therapy in patients with STEMI is reperfusion. That's all. because you have to open up the vessel. The vessel is completely gone. It's completely blocked. It's occluded. You have to reperfuse, reopen the vessel. So what are the ways for reopening? So you can follow primary thrombolysis strategy or a primary PCI strategy, or you can do a primary thrombolysis strategy, then go to a PCI. Okay, so plus or minus you can do a PCI. Okay, in case if PCI has failed, or if you think that in case if the lysis have failed, or in case if you think that thrombolysis may have been effective or doubtfully effective, then in that case you can follow it up with the PCI. So you can follow a primary thrombolysis technique, or you can follow a primary PCI technique where you are stenting. But you know, the best is always doing a primary PCI. That is the best. Okay, that's the best, primary PCI, because it's evidence based. You're going to see in the monitor. The patient is lying in front of you, you are injecting the dye, you are seeing there is no flow in the vessel. Then you are putting a stent and seeing the flow is re-established. You are establishing the Dimitri flow. Okay, that is the reason why PCI is always better. And what about end-STEMI unstable angina? In end-STEMI unstable angina, the goal is not reperfusion. There is already some flow that is still there. So the goal is not really reperfusion. In end-STEMI unstable angina, the goal is to reduce the thrombus burden, and to reduce the phasic distal embolization. Okay, phasic distal embolization. Why there is phasic distal embolization? Remember, there is some flow is still happening. So it's going to take pieces of the clot, pieces of clot, and it's going to shower it to distal areas. So there will be phasic distal embolization. And this is the goal. So to do this, anticoagulation is more than enough. That's all. But remember, I'll tell you one thing. Whenever, troponins are elevated, trust me, this is a common rule in practice. Whenever troponins are elevated, you have to push the patient to a cath lab. Either immediately or later, depends on the situation. The patient is in cardiogenic shock, I'm going to push the patient immediately. Even in an end STEMI. Okay? Or if the STEMI, definitely I have to push the patient to the cath lab immediately within 2 hours if possible. Or in some patients, the end STEMI, you are going to push the patients a little later, maybe after 2 hours or 24 hours. But if the troponins are elevated, you have to push the patient to the cath lab. There's no doubt about that. The coronary angiogram is mandatory whenever the troponins are elevated, because troponin elevation is an independent marker of mortality. See, there are 3 important markers that you need to know for exams. One is total bilirubin, next is serum creatinine, next is troponin. Okay, these 3 are basically independent markers of mortality. Due to any reason, in the ICU, if total bilirubin is elevated, mortality is high. Creatinine elevated, new AKA, okay, mortality high. Troponin elevated, mortality high. Due to any reason, irrespective of what is the cause. It could be ACS, it could be COVID, it could be some other thing. It could be just due to critical care related cytokine injury to the heart, doesn't matter. If any of these markers are getting elevated in a critically ill patient, ICU, or any hospitalized individual, they are independent predictors of death and mortality. That is why total bilirubin is something that will be there in almost every single score you see. See, what is MELD score? CBI, creatinine, bilirubin, INR, right? Bilirubin is there. See, MADRS discriminant function, 4.6 multiplied by prothrombin time test minus control plus total bilirubin. Bilirubin is still there. Look at child Turcotte-Pook score. You have ascites, encephalopathy, albumin, bilirubin, PTINR. Bilirubin is still there. Look at a Seattle score for graft versus host disease. In that also you'll have total bilirubin. Look at SOFA score, not the Q-SOFA, the original SOFA score. There also you'll have total bilirubin. So that's very, very important. That will be there in almost all the scores. These are all independent predictors of survival and death. Okay, that's why these are extremely important. Okay, to understand for exam. So now you know the goals. Okay, so what all you're going to do in some specific different situations. Okay, so now that is the explanation for this question. Okay, so now with the help of cardiac markers, we have discussed so many other things. Another common question that students ask is how to diagnose reinfarction, because many students still believe that the marker of choice for reinfarction is CKMB. CKMB is not a good marker because it's neither sensitive nor specific. So how will you diagnose reinfarction with troponins? It's pretty simple, right? So remember, let us assume, what is reinfarction first of all? If the patient is having infarction within the next 28 days, Okay, if infarction occurs within the next 28 days, that's called as reinfarction. So let us assume the patient is having a downward trend of troponin, or the troponin has stabilized. If the patient is getting a new ACS, okay, if the troponin is getting a new ACS, new event, new acute event, what's going to the troponin? You're going to get another spike. So definitely if you are serially doing troponin, you know at that point what is the troponin. And you're going to repeat the troponin after 3 to 6 hours. And you can clearly say that after 3 to 6 hours, the troponins have elevated, okay, by more than 20%. Okay. After 3 to 6 hours, you can say that troponins are changed by more than 20%. That becomes a new acute event. That's all. Similarly, same thing. If the troponin levels are stable, okay, if the troponin levels are already come to the baseline, or if it is stable, if it's a new event, it's going to produce another spike. So prove that the change is more than 20%. It tells you it's a new acute event. That's a reinfarction. That's it. Gone. So why you want to use CKMB? So stick to troponin. More sensitive, more specific, more effective in clinical practice. Okay, use the 20% rule. It's done. Some people may ask, sir, what if the cardiac markers are in the rising trend? Suppose if the markers are already rising. Okay, if the markers are already rising. And if I get a new event, okay, whether this is due to the previous event or it's a new event, how will I know? That is why guidelines are saying clearly, if the markers are in the rising trend, repeat with me, if the markers are in the rising trend, you can't diagnose ACS with any cardiac marker for that matters. You cannot diagnose a reinfarction with any cardiac marker for that matters. If the markers are falling or if the markers are stable, then only you will be able to diagnose a reinfarction. I think you are clear. If rising trend, you cannot diagnose a reinfarction. If it's falling or stable, then only you can diagnose a reinfarction. I'll repeat, if it's falling or stable, then only you can diagnose reinfarction with that 20% rule. That's it. Now you know that troponin is very, very, very good for diagnosing reinfarction as well. Coming to question number 2. Okay, a 60-year-old woman with coronary artery disease and hypertension in the ICU, recovering from a partial colectomy. Okay, some surgery has been done, and post-operative day 3, she developed confusion. Sorry for the English. My English is very bad. She developed confusion. Her temperature is 37 degrees Celsius. BP is 88/60, which means she is in a state of a shock. 80/60 millimeters of mercury. Pulse rate is 118 per minute. Regular, and respiratory rate is 28 per minute. Her pulmonary capillary wedge pressure is 20 millimeters of mercury. Okay, her ECG is unchanged. And cardiac enzyme levels are normal. What is the most likely cause of the patient's shock? So the clue here is very obvious. That's the PCWP. So what is the diagnosis? Is it Addisonian crisis? Or is it anaphylaxis? Or is it cardiogenic shock? Or is it septic shock? What is the diagnosis? Okay, for this we need to know the various values in a patient with shock. So we have 4 types of shock basically. So what are the 4 types of shock? You have something called as hypovolemic shock. You have something called as hypovolemic shock. You have something called as cardiogenic shock. Okay, cardiogenic shock. Okay, you have something called as distributive shock. Okay, distributive shock. And finally, you have something called as obstructive shock. Okay, obstructive shock. Okay, 4 types: hypovolemic shock, cardiogenic shock, distributive shock, obstructive shock. So what are the types of hypovolemic shock? You have hemorrhagic shock, which means the patient is bleeding out. It could be due to surgery or it could be due to trauma like road traffic accident. And we have non-hemorrhagic shock. Non-hemorrhagic shock. It is due to some other reason apart from blood loss like vomiting, diarrhea, or third space losses. Then third, cardiogenic shock. It could be arrhythmogenic shock, which can be due to brady or tachyarrhythmia, or it could be due to cardiomyopathic shock. Cardiomyopathic shock. Okay, where the problem is poor contractility of the heart, systolic or diastolic dysfunction. Third is distributive shock. What are the types of distributive shock? We have septic shock and we have non-septic shock. Sepsis is due to infection. We know that What are the non-septic cause of distributive shock? In that we have two types. One is called as anaphylactic shock and we have neurogenic shock. And fourth, we have obstructive shock. So in obstructive, you have two types again. One is pulmonary RV type. Pulmonary RV type. So pulmonary means we are talking about pulmonary embolism. RV means we are talking about acute right ventricular failure. So what can cause an acute right ventricular failure? Typically, what's going to cause acute right ventricular failure? RVMI, right ventricular MI. Okay, acute right ventricular failure. What about pulmonary, other cause? Apart from pulmonary embolism, acute pulmonary embolism, you can even think about tension pneumothorax. Tension pneumothorax, but that we can write separately because tension pneumothorax tend to produce tamponade effect. So second cause is tamponade. Okay, tamponade. So tamponade doesn't mean only tamponade. You can include tension pneumothorax also here. Tension pneumothorax also here. So these are all going to cause obstructive cause because tension pneumothorax is also going to compress the heart. And it's going to strangulate, it's going to like squeeze the heart. Okay, that's what it's going to do. So what are the parameters you're going to see? So remember, for any shock, basically the gold standard for any shock, the gold standard for diagnosis and monitoring of your therapy is going to be Swan-Ganz catheter. Swan-Ganz catheter, otherwise called as pulmonary artery catheterization. The gold standard for any shock, okay, is Swan-Ganz, pulmonary artery catheter. So based on pulmonary artery catheter data, how can you classify? So you can write PCWP here, that is called as pulmonary capillary wedge pressure. You can write the cardiac index, okay, that is nothing but cardiac output. We are going to calculate in liters per meter square, that's what we call as cardiac index. Okay, then we are going to write systemic vascular resistance here, SVR. And finally, we can write something called as SVO2. That's called as mixed venous oxygen saturation. Remember, where you find out mixed venous oxygen saturation, that's also a question. The best side for finding out the mixed venous oxygen saturation is the pulmonary artery. Pulmonary artery is the best side for mixed venous oxygen saturation. Okay, see, this is Swan-Ganz data. Right now, we don't use Swan-Ganz routinely for shock patients. That's why this SVO2, in some textbooks, they will give something called as SCVO2. That's called, I mean, not SCOT. The SCO2 means SVC, superior vena cava oxygen saturation, that can be done with the help of a central venous catheter itself. Okay, I'm not going to controversies, but just see the traditional things now. So what is the preload? PCWP. What are these things? PCWP is an index of preload. How much blood is coming back to the heart? Cardiac index is a measure of your pump function. How much the heart is contracting. Pump function. SVR is a measure of afterload. SVR is a measure of afterload. SVO2, mixed venous oxygen saturation, is a marker of tissue perfusion or oxygen extraction or tissue perfusion. Is a measure of oxygen extraction and tissue perfusion. Okay, so that's what we have SVO2. That is mixed venous oxygen saturation. So what will be the PCWP in a hypovolemic shock? It will be definitely low because the blood is getting lost from the vascular compartment. So the amount of blood coming back to the heart will be low. What about the PCWP in patients with cardiogenic shock? It will be high. This is a very important point. PCWP will be high. PCWP will be high. PCWP will be high. Okay, remember our patient's PCWP is 20 millimeters of mercury. What is the normal PCWP? 6 to 12 millimeters of mercury. Anything more than 12 is increased. So PCWP high. So clearly I can say our patient is having cardiogenic shock. That's the right answer for this question. Option C, cardiogenic shock. So what about PCWP in patients with distributive shock? The problem in distributive shock is peripheral vasodilation. Blood is getting pooled in the peripheral vasculature. It's not coming back to the central circulation and back to the heart. That's why PCWP will be usually decreased in patients with distributive shock. And what about obstructive shock? It can be decreased or it can be increased. It depends on what is the type of shock. If it's going to be pulmonary RV type, it's going to be decreased. Okay? Because why it will be decreased if it's pulmonary RV type? Because in pulmonary embolism or in right ventricular failure, the blood is not going to the left side at all. You know that PCWP is a measure of left atrial pressure. It's an approximate measure of left atrial pressure. So if the blood is not going from right side to the left side, how the left atrial pressure will be normal or increased? So it will be low if it's a pulmonary RV type. On the other hand, if something is strangulating the heart, compressing the heart, your PCWP will be increased. So this is what is going to happen in tamponade. If it's going to be tamponade, the PCWP will be high. That's it. So what about cardiac index? Cardiac index in patients with hypovolemic shock generally will be decreased. There is no doubt about that. What about cardiogenic shock? It will be decreased. Okay, what about distributive shock? In distributive shock, it depends. Okay, it can be decreased or increased, but for exam sake, you can assume it's increased because of hyperdynamic circulation. Because in sepsis, too much cytokines, there will be hyperdynamic circulation. That's why in exams, you answer it's increased, but sometimes it can be decreased also. Usually, it will be increased. What will be the cardiac index in obstructive shock? Obviously, it will be decreased. What about systemic vascular resistance? Because of high catecholamine levels, okay, because of sympathetic response, the SVR will be increased in all the shocks except the septic shock. That's why this is a very, very important point. In distributive shock alone, because of peripheral vasodilation, the systemic vascular resistance will be low. In all the other shocks, it will be increased. What about SVO2, mixed unit oxygen saturation? Remember, it will be decreased. But in septic shock and other types of distributive shock, it may be increased. That's a very important point. Why? Because in septic shock, just assume, I mean, there are plenty of reasons, but assume that the patient is having vasodilatation. Because of vasodilatation, the blood is going to move very, very fast across the vasculature. So there is no time for the cells to extract oxygen. There's no time. So oxygen, whatever is there in the arterial side, is not going to get extracted that much. So a lot of oxygen will go to the venous side also. So the mixed venous oxygen saturation will be increased because the tissues are unable to extract oxygen. So this is the traditional thinking, but currently the understanding is very simple. In distributive shock, the cytokine levels will be high. Because of that, there will be a baseline cellular level defect that prevents the cells from consuming a lot of oxygen. So that's the reason why SVO2 will be high, but no matter what, in whatever way you understand, it doesn't matter. Your SVO2 must be high in patients with distributive shock. Okay, so this is a very, very important table, Swan-Ganz data. So that tells you that which will tell you what is the type of shock that the patient is having. So what about the CVP then? Central venous pressure. This is a bedside assessment. You can assess through JVP also, right? So CVP in a patient hemorrhagic shock will be low. Cardiogenic shock, it will be high. In distributive shock will be low. In all the types of obstructive shock, it will be high. Irrespective of whether it's pulmonary RV type or it is tamponade type, the CVP will be high though. Okay, so that's a very important point. And what about treatment? So initial treatment, exam, most of the times they will talk about the initial treatment, right? So what about the initial treatment? So in hypovolemic shock, you are going to use IV fluids. Okay, IV fluids plus or minus blood products, depending on the indication, plus or minus blood products. So what is the most important indications for blood products? Let me tell you here itself. So first of all, generally as a common rule, so hemoglobin less than 7 means you are going to use PRBCs. But depends, if the patient is a coronary artery disease patient, then you can keep a threshold of even 9. Remember, if the patient is having ACS or some severe coronary artery disease, even 9 could be the threshold. This is very variable. But in most situations, we are going to keep an ICU threshold of 7. Definitely have to transfuse. Okay. Apart from that, hemoglobin is a very, very poor marker for blood transfusions. That is why you have to use course in the setting of trauma. We are not going to talk right now. We are going to talk later on. Okay, about what will be the different scoring systems that we use in trauma to transfuse blood products. Generally, platelet transfusion can be done if the platelets are less than 50,000 and the patient is bleeding. You can transfuse cryoprecipitate if the patient is having a fibrinogen level of less than 100. And you can transfuse FFP if the patient's INR is more than 2. INR more than 2, FFP. Cryoprecipitate when fibrinogen is less than 100. PRBC whenever HB is less than 7, but in trauma setting it's variable. And platelets whenever the patient is bleeding and having a platelet of less than 50,000. Okay, if the patient is not bleeding, then 10 to 20,000 will be the cutoff, but the patient is bleeding, then less than 50,000 is the cutoff. Okay, so what about cardiogenic shock? So if it's an arrhythmogenic shock, if the patient is suffering from arrhythmias, okay, then treat the arrhythmias. So if it's a bradyarrhythmia, you know the first line treatment is going to be atropine. If the patient is in shock, first is atropine. If it's a tachyarrhythmia, it depends, okay, on whether the patient is having a narrow complex or a wide complex, it all depends. But in general, remember our patient is in shock, right? Our patient is in shock. And if the patient is in tachyarrhythmia, you are going to perform synchronized DC cardioversion. Okay, you need to be very clear about that. The patient is in shock and having a tachyarrhythmia, synchronized DC cardioversion. Then What about cardiomyopathic shock? If the patient is having cardiomyopathic shock, then what will be the treatment of choice? You're going to use inotropes. Inotropes. But remember, there are two types of inotropes in practice. One is vasodilating inotropes, and second is non-vasodilating inotropes. So what are the examples of vasodilating inotropes? It's going to be dobutamine and milrinone, commonly used drugs. Dobutamine is a pure beta-1 plus or minus beta-2 agonist. That's why that beta-2 fraction can cause vasodilation. And milrinone is a phosphodiesterase 3 inhibitor. Okay, both can cause severe vasodilation and they can reduce the BP further. That's why these are vasodilating. What are non-vasodilating inotropes? So non-vasodilating inotropes are basically noradrenaline and dopamine. But the first choice in any shock is noradrenaline. If they ask you in any shock, noradrenaline will be the first choice. So don't use vasodilating inotropes in a patient with shock. In shock states, vasodilating inotropes are contraindicated. You should not use. You should use only non-vasodilating inotropes if the patient is in shock. Then what about septic shock or any kind of distributive shock? Remember, if the patient is in septic shock, first treatment is IV fluids. You have to give plenty of IV fluids because patient will be definitely fluid responsive. Plus, if the patient is not responding, you have to use vasopressors. So what are the vasopressors of choice? You have to use either noradrenaline or you have to use vasopressin or a combination of both together, noradrenaline and vasopressin. But trust me, in anaphylactic shock also we do the same, but in exam if they talk about anaphylaxis, anaphylactic shock, then you can answer adrenaline. What is the dose of adrenaline? It is 1 milligram, 1:1000 IM. It's not 1 milligram, even 0.5 milligram is fine, but it should be given IM and the dilution is 1:1000. Okay, so that is the number that you need to know. And what about the obstructive shock? Obstructive shock, most of the times treatment of cause. That's going to be more important. Suppose if the patient is having pulmonary embolism, you have to thrombolize the patient. In previous lecture itself, we have seen clearly that any pulmonary embolus with hypotension is an indication for thrombolysis. Plus, you have to use anticoagulation like heparin. For sure, there is no doubt about that. And what about tension pneumothorax? If the patient is having tension pneumothorax, then you are going to use needle thoracostomy. The next immediate urgent treatment will be needle thoracostomy. So what is needle thoracostomy? You are going to use a wide bore needle like 14G or a 16G needle and you are going to insert in the either second intercostal space in the mid-clavicular line or in the fifth intercostal space in the mid-axillary line. But current models say that the fifth intercostal space in the mid-axillary line is better according to the recent ATLS protocol also. So you can opt for that if it's given in the exams. And if it's going to be a tamponade and if the patient is in shock, you know very well the treatment is going to be pericardiocentesis. Okay. And if it's going to be RVMI, then you are going to use inotropes. You're going to use IV fluid and inotropes. Remember, this is something I think I've discussed already in one of my previous lectures that if it's going to be right ventricular MI, then you have to use IV fluids and you have to target a JVP of approximately 10 to 14 millimeters of mercury because our right ventricle is preload sensitive and left ventricle is inotrope sensitive. Right ventricle is not going to respond that much to inotropes. This is a point I've told you already in one of my previous lectures if you watch the YouTube sessions. So target JVP is 10 to 14 and you're going to give IV fluids till you reach the target JVP. Remember, you should never use IV fluids in a left ventricular failure. If it's a right ventricular failure acute, then IV fluids are indicated. And you have to avoid all the drugs that reduce preload. You should not use diuretics, you should not use nitroglycerin, you should not use any drug that reduces the preload because RV is preload sensitive. If you reduce the preload, the patient's shock will get worse. Okay, so that's it. So this is the entire dynamic. So this one table is so important. I hope you get it. So, I mean, there are plenty of questions in that one table which I've told you. And at least one question is something that will surely get in the exam. Okay, so see this table very carefully. Even though the question may be very simple, but the discussion I have done is quite extensive. Then moving on to question number 3. So a 70-year-old woman was admitted with acute exacerbation of COPD. After initial treatment with salbutamol and corticosteroids, they are given salbutamol and probably dexamethasone or hydrocortisone. Respiratory rate has normalized and the SpO2 is now 80 to 92, which is the target in many patients with acute exacerbation of COPD. But the pulse rate is still 110 per minute. So you got suspicious and the patient's not having dyspnea or cough, but the pulse rate is around 110 beats per minute. So which of the following is very likely to be seen in the patient? We are talking about what is the usual arrhythmia that you will encounter in the setting of acute exacerbation of COPD. Is it atrial fibrillation, or is it atrial flutter, or is it multifocal atrial tachycardia, or is it ventricular tachycardia? What you will expect in a patient with acute exacerbation of COPD. So the right answer for this question is MAT, that is multifocal atrial tachycardia. So that is what you're going to see very common in the setting of pulmonary disease. So remember, MAT is typically an arrhythmia that's going to occur in the setting of a pulmonary disease. Remember, atrial fibrillation is the most common ICU arrhythmia. Okay, if they ask you what is the most common ICU arrhythmia, if you ignore sinus tachycardia, then AF will be the most common rhythm. Most common ICU arrhythmia is atrial fibrillation. But in severe pulmonary disease, especially in COPD and all, acute exacerbation COPD and all, the most common arrhythmia that you encounter is multifocal atrial tachycardia. So what is the thing that's going to help you diagnose a multifocal atrial tachycardia? You should have at least 3 different P wave morphologies. 3 different P wave morphologies or multiple different P wave morphologies, and the patient's rhythm will be irregular. So it's a common tendency in the exam to answer atrial fibrillation for any irregular rhythm, but you need to be careful. But MAT will also be irregular. In atrial fibrillation, you will not have P waves. In atrial fibrillation, you will not have P waves. But in MAT, you will have P waves, and you will get at least 3 different P wave morphologies. Okay, what about atrial flutter? So atrial flutter typically lead to, you are going to see the sawtooth pattern. So that's the only thing that you can use to diagnose an atrial flutter. So in atrial flutter, you're going to see the sawtooth pattern, the negative inverted P waves. These are called as F waves or flutter waves. And what about ventricular tachycardia? Ventricular tachycardia is going to be a wide complex tachycardia, number 1. It's basically. And you know the definition of ventricular tachycardia. What is the definition? There should be at least 3 consecutive ventricular premature contractions. Okay, and that should occur at least at a rate of more than 100 per minute. Some books will tell 120, but nevertheless. So at least 3 consecutive ventricular premature contractions occurring at a rate of 100 beats per minute. For that matters, if you're having a fully sinus rhythm like this, if you're having a fully sinus rhythm, but suddenly you're getting 3 ventricular premature contractions like this, 3 ventricular premature contractions, then you're getting a sinus rhythm again. Even this is considered to be a VT if you are going to get the rhythm at a rate of at least 100 beats per minute. If the rate of this rhythm is, this 3 beats is more than 100 per minute, still it will be called as ventricular tachycardia. So what are the types of ventricular tachycardia? There are multiple classifications. The 2 important ones I will say. The first thing says that non-sustained ventricular tachycardia and sustained ventricular tachycardia. Non-sustained VT means it will be for sustained for less than 30 seconds. Sustained ventricular tachycardia means it should be sustained for more than 30 seconds. So second classification says monomorphic VT versus a polymorphic VT. Monomorphic VT versus a polymorphic VT. Monomorphic VT means single morphology, only one morphology of QRS. Polymorphic VT means multiple morphologies. Whenever you have a background polymorphic VT on top of a long QT syndrome, it will be called as torsades pointer. So torsades pointer is nothing but a polymorphic VT only, but if it occurs on top of a long QT syndrome, you are going to call it as torsades. That's it. Okay, so these are the different definitions of different arrhythmias. The right answer for this question is going to be option C, multifocal atrial tachycardia. So coming to question 4. A patient with Epstein's anomaly presented with arrhythmia. What is the long-term management? Option A is radiofrequency ablation. Option B is AV nodal ablation. Option C is amiodarone. Option D is verapamil. So first of all, you need to know what is going to occur in patients with Epstein anomaly, very commonly. Then only you can answer this question. So remember, in patients with Epstein anomaly, usually you will have WPW syndrome. And there will be axillary pathways. And the WPW associated with Epstein syndrome will be having multiple pathways, multiple tracks. Okay, multiple tracks. That's a very characteristic feature of Epstein. You'll have multiple tracks. Here, there, multiple tracks. So it's very difficult to treat this WPW in patients with Epstein's anomaly. So you know WPW's long-term best treatment is going to be radiofrequency ablation. There is no doubt about that. And some other features of Epstein's anomaly. So remember, everyone knows that Epstein is related to lithium intake in the antenatal period. So there are plenty of causes. Many cases right now are not due to lithium intake, but traditionally that's asked in exam. So you can assume that antenatal lithium intake is usually going to result in development of Epstein anomaly. So what is Epstein's anomaly? It is atrialization of right ventricle. Atrialization of right ventricle. So that is the one point that you need to know. Atrialization of right ventricle. So what is atrialization? There will be displacement of the valve. Okay. Especially the septal leaflet of the tricuspid valve will be displaced. And because it's displaced, it will be very small. But the other leaflet, the anterior leaflet, it will be large. It will be compensating for that. It will be large and it will become sail-like. That's why if they tell sail-like tricuspid valve leaflet, sail-like tricuspid valve leaflet, even that is a feature that is suggesting Epstein's anomaly. So because of the displacement of the tricuspid valve down towards the right ventricle, the atrium will become bigger and the right ventricle will become smaller. That is the reason why patients with Epstein's anomaly tend to develop right ventricular failure, chronic right ventricular failure. And they'll have a large right atrium. Because of right ventricular failure, most of the patients will have severe TR. Not just because of right ventricular failure, patients are having that defective leaflet. That is also the reason why they're going to have severe TR. And this itself is going to result in development of even more huge right atrium. In fact, the entire heart will be made of right atrium in some patients. Other chambers will be small. That's why in X-ray, you are going to see box-shaped heart. In Epstein's anomaly, box-shaped heart. That is because of huge right atrium. Box-shaped heart. And many patients can have associated ASD. Not some, in fact, many patients will have ASD because the amount of blood that can pass through the small right ventricle and into the pulmonary artery is very less. So a lot of blood will accumulate in the right atrium. Where this blood will go? It has to get shunted towards the left atrium. And there will be defective closure of the foramen ovale because of high pressure in the right atrium in this patient. That's why the foramen ovale will be open, and that is what we call it as ASD in some patients. Okay, ASD may be there. Large ASD will be there. And that is also the reason why many patients can have cyanosis. Epstein's is a cyanotic congenital heart disease. They can have associated cyanosis. And in exam, typically they will use the term called as intermittent cyanosis, which means whenever the pulmonary resistance increases. Why intermittent cyanosis? Whenever the pulmonary resistance increases due to some reason, okay, the patient will develop more like TR and more blood flow towards the left atrium, resulting in mixing of the blood and cyanosis. Okay, intermittent cyanosis. That occurs whenever the pulmonary vascular resistance increases. Okay, treatment of choice, of course, is going to be surgery because it's a cyanotic congenital heart disease. As I told you, the other associated problem is WPW syndrome. And in general, in exam, how will you diagnose WPW syndrome? In the ECG, you are going to see two classic features. What are the two classic features? Number one, short PR. I'll repeat, short PR. Number two, you're going to see delta waves. So remember, these changes are seen only when the ECG is taken at sinus rhythm. During arrhythmias, these changes will disappear. Only during sinus rhythm, these changes will be there. Short PR and delta waves. What is short PR? PR interval of less than 120 milliseconds or less than 0.12 seconds. That is short PR. What are delta waves? You're going to have slurring of the QRS. Okay, initial part of the QRS will be slurred. That's called as delta waves. That's a direct sign of the presence of axillary pathway. Delta waves. So these are signs of WPW syndrome. Okay. So immediate management of WPW syndrome is different because they are going to produce arrhythmias. What are the arrhythmias they are going to produce? The arrhythmia they are going to produce is AVRT. AVRT. That is AV nodal reentrant tachycardia, or sorry, not AV nodal, atrioventricular reentrant tachycardia, otherwise called as atrioventricular reciprocating tachycardia. So what are you going to get? So you are going to have AV node over here. You're going to have axillary pathway here. So what's going to occur? There's going to be a reentrant circuit that's going to get formed. So if it's going to go down the axillary pathway, going down the AV node, it's going to come up through the axillary pathway back into the atrium. This will be called as orthodromic conduction. Orthodromic conduction. On the other hand, if you're going to have, okay, other way around. Okay, we're going to get something other way around. Like if the circuit is going down the axillary pathway, and it's going to go up the AV node and come back to the atrium. So this route is called as antidromic conduction. This route is called as antidromic conduction. Antidromic. So orthodromic conduction will have a narrow complex tachycardia. It will mimic an AV NRT. Antidromic conduction will sometimes make a ventricular tachycardia because it's a wide complex tachycardia. Antidromic conduction is a wide complex tachycardia. Orthodromic is a narrow complex tachycardia. So treatment of each and every arrhythmia is beyond the scope of the current discussion. Many times you are going to use the same strategy as that of narrow complex and wide complex tachycardia in the setting of emergency. So don't think anything beyond that in exam. Okay, the long-term treatment of any WPW syndrome is going to be radiofrequency ablation. You have to identify where is the tract in the electrophysiological studies in EPS and you have to ablate that tract. So that's the treatment of choice. AV nodal ablation you can use in patients with atrial fibrillation, chronic long-standing atrial fibrillation. We call it as permanent atrial fibrillation with uncontrolled ventricular response. Which means you have tried everything, it's failed, and the patient is having tachycardia continuously because of long-standing permanent atrial fibrillation. You can do AV nodal ablation, but of course after that you need to pace the ventricles also. Amiodarone verapamil will be tried in selected situations. For example, amiodarone can be tried in a wide complex tachycardia. Okay. Usually verapamil will be tried as an alternative to beta blockers. Many times as an alternative beta blockers, especially in the setting of irregular narrow complex tachycardia. In the setting of irregular narrow complex tachycardia, many times you can use verapamil as an alternative to beta blocker. But the first choice is still beta blockers only. Okay, these are the explanation for other options. So I think this question is sound and clear, and let us move on to the next one. You have a 48-year-old man with diabetes and hypertension presenting for an annual checkup. His current medications are metformin and telmisartan. His temperature is 37.2 degrees Celsius, which is normal. Heart rate is 82 normal. BP alone is somewhere around 146/84 millimeters of mercury. And respiratory rate is 18 per minute. Laboratory tests show HbA1c of 7.5%, which is definitely elevated. Total cholesterol is 225 milligrams per deciliter. LDL alone is 165 milligrams per deciliter. HDL cholesterol is 30 milligrams per deciliter. That doesn't matter anyway. Triglyceride is around 150. Which of the following targets are correct? So option A states like target LDL should be less than 100 and BP target should be less than 130/80. And option B states target LDL is less than 70 and BP should be less than 130/80. Option C states target LDL is less than 100 and A1C should be less than 9%. And option D says target LDL should be less than 70 and A1C should be less than 8%. The right answer for this question is going to be option A. The target LDL should be less than 100 and the BP should be less than 130/80 millimeters of mercury. So for this, you need to understand the statin guidelines. This is something that's very, very commonly asked in both NEET as well as INA-CET exams. So what are the targets? And what are the statin guidelines right now? What are the cholesterol guidelines right now? So remember, you can use statins for the sake of primary prevention and you can use statins for the sake of secondary prevention. For the sake of secondary prevention also. What do you mean by secondary prevention? Which means patient is already a known case of coronary artery disease or a cerebrovascular disease like TIA and stroke or peripheral arterial disease. Patient is already a known case of either CAD or CVD or PAD. In this setting, you have to use statins irrespective of whatever the cholesterol is. So all patients, irrespective of what LDL is, you are going to use statins. All patients should receive statins. And generally, it is preferable to use a high-intensity statin. So what are high-intensity statin? You're going to use either atorvastatin at a dose of 40 to 80 milligram, or you can use rosuvastatin at a dose of 20 to 40 milligram. Anyone. But remember, rosuvas at a dose of 5 to 10 and atorvas at a dose of 10 to 20 is a medium intensity statin only. It's a moderate intensity statin. It's not a high intensity statin. So if you can't use high intensity statin, guidelines says that you at least try and use maximally tolerated dose. Whatever dose that the patient is maximally tolerating, at least use that dose. If you are not able to use high intensity statin because of some reason like myalgia, then use maximally tolerated dose. Okay, that's the guideline. And what are the targets? The target LDL cholesterol in patients with a known case of some coronary artery disease or peripheral arterial disease or cerebrovascular disease less than 70. This is something that's very important to understand. For secondary prevention, the target LDL is less than 70. So what about primary prevention? Primary prevention we don't do. So here the patient is not a known case of coronary artery disease, cerebrovascular disease or peripheral arterial disease. But still we can use statins in some patients, selected patients. What are those patients? Number one, those who are having LDL of more than 190. Anyone with LDL more than 190, definitely it's an indication for statins. And second, those patients who are aged more than 40, more than or equal to 40, and having LDL in the range of 70 to 189. LDL in the range of 70 to 189. Okay, not very low, not very high, but age more than 40. So now you can split into diabetes mellitus, those who are having diabetes, and those who are having no diabetes. Those without diabetes. Those with diabetes, definitely I need to use statins. There's no doubt about that. Definitely I'll use statins if the patient is having diabetes. And this could be moderate or high intensity statin depending on the underlying clinical status. If the patient is not having diabetes mellitus, then in selected patients, I will be using statins. Selected patients, I can use statins. How can you select that this patient will be requiring statins or not? So ACCHA clearly says that you have to use something called as 10-year cardiovascular risk calculator that is available in the ACCHA website. 10-year cardiovascular risk calculator is there. This is available for those who are aged 40 and above. Okay, here if the cardiovascular risk is more than 20%, definitely you have to use statins. There's no doubt about that. If it is less than 5%, you need not use statins. Okay, if the risk is somewhere around 5 to less than 20%, that is 5 to 19.9%, then you can consider using statins if the patient is having ASCVD risk enhancers. And ACCHA gives a separate list of risk enhancers. I'm not going to talk about that right now. There are plenty of risk enhancers. High HSCRP, okay, high triglyceride values, patients who are having metabolic syndrome, patients who are having CKD, patients who are having woman-related problems like preeclampsia, premature menopause. Okay, there are plenty of risk enhancers. Or chronic inflammatory states like rheumatoid arthritis, HIV, IBD and all. Okay, if yes, then you can consider using statins. If risk enhancers are not there, then you can probably wait on. You need not use statins. So that's what the guidelines are saying. Okay, so these are the statin guidelines. But in case if you are starting statins, so what statins you will start for this group? LDL more than 190. You're going to start with high intensity statins. Okay, here moderate to high intensity. For group number 2, moderate to high intensity depending on the clinical indication. For group number 1, definitely it is high intensity statin. No doubt about that. So what will be the target LDL? Target LDL. Target LDL in patients who are using statins for the sake of primary prevention. It is less than 100. Okay, not less than 70. Only for secondary prevention, the target LDL is less than 70. For primary prevention, the target LDL is less than 100. Look at our patient. Look at our patient. Our patient is 48-year-old, which means age more than 40 and not having history of ASCVD. So if you are going to use statins, it's going to be for the sake of primary prevention only, not for the sake of secondary prevention. And our patient is having diabetes, age more than 40 plus LDL. Look at LDL. LDL is 165. It is 70 to 189. Age more than 40. 70 to 189 LDL. Having diabetes. Definitely I will use statins. And the target LDL is going to be less than 100. And according to the current ACCHA norms, all the patients should have a BP. This is a universal target. Have a BP of less than 130/80. So if the patient is having BP of 140/80, 146/84, which means more than 140. So the patient is hypertensive. So I have to use antihypertensive drugs and I have to bring the BP down to less than 130/80 millimeters of mercury. So the right answer for this question is option A. Hope you understand. So option B would have been correct in case, okay, option B would have been correct in case if the patient is already a known case of ASCVD, like coronary artery disease or peripheral vascular disease or cerebral vascular disease. Then option B would have been correct. Option C is wrong because for most patients we keep a A1C target of less than 7. So that's why it is wrong. It's not correct. So C and D are just dummy choices. Right answer is option A. And what are the alternative drugs that you can use? Remember, the alternative drugs that you can use are ezetimibe. Not alternative, add-on drugs. In case if your cholesterol control is not that good, then you can add ezetimibe, which is an NPC1L1 transport inhibitor, NPC1L1 transport inhibitor that stops the intestinal absorption of cholesterol. Then you can use PCSK9 inhibitors. There are two drugs are there. One is called as evolocumab and second one is called as alirocumab. Both drugs are not produced by any pharma companies in India. So you have to import. So it's very costly. Monthly injections cost around around 17 to 20K, I guess, depending on the pharmaceutical company that you're procuring from. And when you use fibrates like probably fenofibrate or gemfibrozil, when you're going to use, only when triglyceride levels exceeds 500. So then only you're going to use fibrates. Otherwise, no fibrates. This is to reduce the risk of pancreatitis. This is to reduce the risk of pancreatitis. Remember, fibrates doesn't reduce cardiovascular risk. No cardiovascular benefit with fibrates. That's a very important point. Please underline it. No cardiovascular benefit. So if you want to reduce cardiovascular risk, statins are the first choice. Absolutely no doubt about that. Fibrates have zero cardiovascular benefit. It's been proven in multiple trials. You got a recent trial as well, which is a very excellent trial published in NEJM in 2021, but that's not important for you. All it's important for you is fibrates have no cardiovascular benefit. So you're going to give fibrates only if the triglycerides more than 500. That is to reduce the risk of pancreatitis. That's all. So SDMIP, PCSK inhibitors have some cardiovascular benefit at least. And when we currently in India, where we use PCSK inhibitors is whenever the LDL control is not good despite your statins and SDMIP, we use PCSK9. Or alternatively, another important indication is patients who are having high lipoproteinemia, because statins are very, very poor in controlling lipoproteinemia. PCSK inhibitors are good. So if you want to reduce lipoproteinemia, the only two drugs that you can use right now is PCSK inhibitors and niacin. Two drugs can be used, but niacin is not commercially available in market. So PCSK inhibitors we prefer in the current era, especially those who are having multiple cardiovascular events, recurrent MI, stroke, so many problems, along with that high lipoproteinemia. The target lipoproteinemia is less than 50. If it's more than 50, you can consider using PCSK inhibitors in that setting. So anyway, so this is a little complicated guideline, but I think I have given the crux of whatever the guideline is. Coming to question number 6, you have a 54-year-old man who comes to the clinic because of intermittent chest pain. It describes the pain as a vague sense of nausea and chest tightness. The pain episode lasts 1 to 2 minutes and occur randomly. He does not exercise and has a significant smoking history, is moderately obese and is not in apparent distress. His BP is 152 upon 88 millimeters of mercury. Our ECG lights and biomarkers are normal. Which of the following is the most appropriate next step in diagnosis? Are you going to use stress myocardial perfusion imaging? Are you going to use cardiac CT angiogram? Are you going to use stress ECG? Are you going to use coronary angiogram? So what is the next appropriate step in this patient? What is the time period we have wait before prescribing add-on drugs? 3 months, okay, generally. 3 to 6 months is the usual timeline that we wait, but 3 months will be the ideal cutoff. So we can wait after adding the add-on drugs like ezetimibe or PCSK9 inhibitors. Okay, many people are answering correctly. The right answer is stress ECG. That's correct. But honestly speaking here, because the question is all about stress testing, we are talking about stress ECG. But cardiac CT angiogram is also one of the important emerging techniques that considered to be very, very excellent, okay, in the modern era. But nevertheless, so what is the approach to stress testing? How will you do a stress testing? So stress testing. So how will you approach? What are the ways? What test you will choose? It depends, okay. When you are preferring a stress testing, see where the patient is able to exercise or not. Patient is able to exercise or not. So if yes or no. If the patient is not able to exercise, then you are going to use a pharmacological stress. Pharmacological stress. What are the options for pharmacological stress? We can use dobutamine, we can use adenosine, or you can use another newer drug called as regadenoson also, which is more selective for the vessels. If the patient is able to exercise, then you have to go for a treadmill-based test only. There's no doubt about that. You have to use a treadmill-based test. If you are using a treadmill-based test, what is the next step? We have to choose an imaging modality. What kind of imaging modality you will choose? For that, you need to see whether the patient is having any baseline ECG changes or not. Baseline ECG changes or not. So what are the baseline ECG changes that are considered to be significant? One is ST depressions more than 1 millimeter. Okay, any ST depression more than 1 millimeter is very significant. Baseline itself, they are having so much of ST depressions. And left bundle branch block. That's a very, very important point. LBBB will confound so many things. So they can produce ST elevation, depression, T-wave inversion. Okay, so many problems the LBBB can create. So in the presence of LB, we don't consider a treadmill ECG. or if the patient is using digoxin, or if the patient is having WPW syndrome. Okay, in this situation, it's better don't use ECG because already there are plenty of baseline ECG changes. So if yes, don't use ECG based testing. So if no, which means the baseline ECG is clear, normal, then you can use a treadmill ECG. In fact, this is a class 1 indication, treadmill ECG. In case if the patient is having significant baseline ECG changes, now you have to go for alternative techniques. You have to use treadmill imaging, not ECG, rather you have to use treadmill imaging. So what are the different types of treadmill imaging? So you can use echocardiogram, okay, to look for regional wall motion abnormality during physical exercise. That's also sign of ischemia. Or you can use an alternative modality called SPECT. SPECT can be tried. But trust me, you cannot use treadmill for PET or cardiac MR because of a lot of reasons. Don't use treadmill for PET and cardiac MR. So understand, how can you ask the patient to run in an MRI gantry? I mean, it's not possible technically. So that's why no PET, no cardiac MR if you're choosing a treadmill based test. You can use only echo, SPECT and ECG. So if there are no significant baseline ECG changes, then go for ECG itself. The patient is having significant baseline ECG changes, go for echo or treadmill based SPECT scans. So SPECT is usually done with the help of certain traces. These are technetium based traces. Technetium based traces which have a half-life of approximately 6 hours. Even though thallium based traces are available, currently we prefer technetium based traces. There are two technetium based traces. One is going to be your sestamib, second is tetrophosphine. So one is tetrophosphine, first tracer. In India, we don't use this commonly. In India, we use sestamib. MIB tracer is very commonly used. Same MIB that you use for imaging parathyroid adenomas also. So, but this for cardiac MIB. Okay, cardiac MIB scan. On the other hand, if you are using a pharmacological stress, so what are the options that we have? Pharmacological stress means you can use anything except ECG. You can use echocardiogram as an imaging modality. You can use SPECT as an imaging modality. You can use PET scan as an imaging modality. Or you can use even cardiac MR as an imaging modality. Okay, what are the traces used in SPECT? I told you already. So thallium based tracer. This is thallium 201 tracer. Tracer number 2 is technetium based traces. Thallium traces have a half-life of around 72 hours. Technetium based traces have a half-life of approximately 6 hours. PET scan. Okay, what about PET scan? PET scan traces are having a very short half-life. That's the problem. That's why we cannot use it along with treadmill, because by the time you ask the patient to run a treadmill and go back to the PET room, like the traces would have been evaporated. So that's the reason. So what is the traces we use? Rubidium 82. All are given in Harrison. Rubidium 82. What is the half-life of rubidium 82? Just 75 seconds. Second tracer, we have something called as O15 water. Okay, O15 water, that has a half-life of approximately 2 minutes. Next is N13 ammonia. N13 ammonia, which has a half-life of approximately 10 minutes. Look at the half-life of these traces. Just seconds to minutes. That's why you cannot use treadmill. Cardiac MR, so that's another point. Okay. So these are the different traces that you're going to test. See, look at our patient. Our patient he does not exercise, but it doesn't mean he's not able to exercise. He will be able to exercise. Okay. And you're planning to choose a stress test. ECG is normal. Baseline ECG is normal. Able to exercise. Baseline ECG is normal. Okay. So no baseline problem, ECG problem. So the right answer for this question is stress ECG. Okay. Treadmill ECG. That is what I'm going to choose. And one point that they will ask you in stress ECG is how will you risk stratify based on treadmill ECG. We're going to use a scoring system called as DTS, Duke's Treadmill Score. Duke's Treadmill Score. So what do you mean by Duke's Treadmill Score? You're going to use the ST depressions and the amount of exercise that the patient is doing in the treadmill. So it is defined as exercise duration. This is a very important question for exam. Exercise duration in minutes minus 5 times the ST segment deviation. It could be ST elevation or ST depression minus 4 times the angina index. So you will be knowing what is the exercise duration using the treadmill itself. ST deviation from the ECG you can pick up. But what about angina index? Angina index, you have 0, 1 and 2. So what is 0? 0 means no angina. Patient is able to exercise throughout the test without any significant problem. So class 1 means non-limiting angina. Angina index of less than 1 means non-limiting angina. Non-limiting angina. So non-limiting angina means patient is developing angina but is able to complete the test. 2 means it's a limiting angina. 2 means it's a limiting angina, which means patient is not able to continue with the exercise and he has to stop the treadmill because of severe angina. So that is 2. So based on the score, if the score is more than or equal to plus 11, which means it's a low risk. Okay, sorry, more than or equal to plus 5, it means it's low risk. If the score is somewhere around plus 4 to minus 10, it is intermediate risk. The score is less than or equal to minus 11, it is high risk. It is high risk. Less than or equal to minus 11. So what you do, low risk patients just continue with the medical therapy. Medical treatment is enough for low risk patients. For high risk patients, you need to definitely consider coronary angiogram. There is no doubt subsequently, because this is a patient with chronic stable ischemic heart disease. So high risk means coronary angiogram as the next step. Intermediate risk patients, you need to perform something else. Like for example, you can perform a SPECT. In fact, according to old guidelines, this is the class 1 indication for SPECT. Or alternatively, you can perform other stress testing or a CT angiogram also. CT angiogram is also okay. So, but according to traditional guidelines, the guidelines have not been updated so far. So it is SPECT. Okay. SPECT is the next step. If the patient is having intermediate risk, or alternative is good alternative is cardiac CT angiogram also. Even that is fine. Or even you can go for other types of imaging modalities like PET or whatever it is. But according to the guidelines, it is SPECT. And somebody is asking, see cardiac CT angiogram or pharmacology test if can't exercise. No, even if the patient is able to exercise, you can prefer a cardiac CT angiogram. That's a totally different kind of investigation. So that's an upcoming investigation. In fact, this is one of the investigation with very good accuracy. In fact, there are some studies which have proven that cardiac CT angiogram is literally having 100% accuracy. And it has a very high negative predictive value, which means if cardiac CT angiogram is normal, it means it is normal. That's all. In Western countries, they don't do diagnostic coronary angiograms anymore. It's a very important upcoming technique, cardiac CT angiogram, which means if it is normal, it is normal. That's all. It has a very high, almost 100% negative predictive value. So which completely can rule out a coronary artery disease in an individual. So I'm not going to discuss about those things right now, but nevertheless, the answer for this question in the context is stress ECG. And what about question 7? A 25-year-old presents to his physician because of increasing shortness of breath, palpitation, and chest pain on exertion. Look at the age 25-year-old. For the past 2 months, cardiac examination reveals a widely split S2 that narrows with inspiration and a systolic crescendo decrescendo murmur that is best heard at the left lower sternal border. Which of the following would most likely lead to decrease in the intensity of the murmur? So now you know the diagnosis. So you tell which is going to reduce the intensity of the murmur. Digoxin, squatting, Valsalva, furosemide, which is going to reduce the intensity of the murmur. So straightforward, you would have made a diagnosis that is HCM. The diagnosis here is hypertrophic cardiomyopathy. And there are two types of hypertrophic cardiomyopathy. One is obstructive type hypertrophic cardiomyopathy, which is the commonest. Almost 70% cases will be obstructive type. And second is non-obstructive type of hypertrophic cardiomyopathy, where you have only 30% of the cases. But remember, 30% of the cases will have no obstruction. And this obstruction, as we have discussed so many times in the previous lectures, it is dynamic obstruction. This is going to be dynamic obstruction. And these patients with obstructive type of HCM, otherwise called as HOCM in common practice, will be having murmur, a classic ejection systolic murmur that will be heard in the left lower sternal border, and it will be a crescendo decrescendo murmur like aortic stenosis murmur. But the most important thing is this murmur will change dynamically. There will be dynamic change in the murmur, because the obstruction is going to change dynamically. So I told you already there is a clue. Whenever the preload reduces, the obstruction increases. That's going to increase the murmur. Whenever the afterload decreases, it's going to reduce the if you want to reduce the afterload, it's going to increase the obstruction, increase the murmur. If you're going to increase the preload, it's going to reduce the obstruction and reduce the murmur. If it's going to increase the afterload also, the same effect, it's going to reduce the obstruction, reduce the murmur. So that's why I told you a clue already. So the arrows are always going to move in opposite directions with regards to the load in patients with hypertrophic cardiomyopathy. That's why it is not hypertrophic obstructive cardiomyopathy. You can remember it as hypertrophic opposite cardiomyopathy. So because arrows are always going to move in the opposite direction. So preload or afterload reducing, obstruction will increase and murmur will increase. Preload or afterload reducing, obstruction will decrease and the murmur will decrease as well. So what are the conditions that reduce the preload? We know that it's going to be Valsalva, the most important condition that reduces the preload. And standing, especially after a squatting. Standing is going to reduce the preload. What about reduction of afterload? So afterload, what's going to reduce the afterload? Amyl nitrate inhalation or any vasodilator. Amyl nitrate inhalation or any vasodilators. Any vasodilator is going to reduce the afterload. And what about increase in the preload? Increase in the preload will occur with leg raising, okay, leg raising maneuver, or probably with squatting. When the patient squats, it squeezes the peripheral vessels, it pushes the blood back into the central circulation, so it increases the preload. What are the conditions that increases the afterload? Isometric hand grip, very important question in exam, isometric hand grip. Okay, so these are the various dynamic maneuvers that we do in practice. So what is the question asking? And another important thing is you need to know that whenever the contractility is increasing, the murmur is going to increase. Whenever contractility is increasing, the murmur will increase as well. So what are the things that increase the contractility? Exercise and some agents like digoxin. So this is going to increase the obstruction and increase the murmur. This is the only thing that goes hand in hand. Increase contraction, increase obstruction, increase murmur. So what about the options? Okay, so digoxin will increase the obstruction and increase the murmur. Squatting is going to reduce the preload. Okay, squatting is going to increase the preload and reduce the murmur. Valsalva is going to reduce the preload and increase the murmur. Furosemide is going to reduce the overall blood volume. Diuretic, reduce the preload, so increase the murmur. So what is the thing that's going to reduce the intensity of the murmur? What is the right answer for this? I don't know why many people are answering C for this. I've seen so many answers C. They're asking what is the thing that's going to reduce the intensity of the murmur. The right answer for this is squatting. That's going to reduce the murmur. If you want to know how squatting reduces the murmur, easily remember, when you squat, you go down. Okay, squat down. Murmur, obstruction is going to go down. How to remember Valsalva? Valsalva means, in Latin, Valhalla, heaven. How will you show heaven? Up. Valhalla, heaven. Valsalva is going to increase murmur. Increase contractility, increase murmur. Clear? Squatting, decrease. Standing, increase. Okay? If you want to raise the leg, you have to lie down. So how will you lie down? Okay? Down, murmur will go down. Valhalla, heaven. Murmur will increase. Squatting, standing. Lie down, leg raising, so decrease. Valhalla, murmur will increase. So that's how you can remember. Pretty much easy. That's all. So that's how it goes. Dynamic auscultation. Okay? So HOCM can occur in elderly. Yes, it can occur in elderly, especially the non-obstructive variants can present in the old age also. The maximum, according to the literature, 67 years of age, till that they have diagnosed HCM, hypertrophic cardiomyopathy, non-obstructive variants. So how will the HCM present? So what will be the presentation? Simple. Number one, most of them will be asymptomatic. Research says that more than 90% of patients will be asymptomatic and undiagnosed. These patients will not be even diagnosed also. They don't even know that patients are having HCM, undiagnosed. Second, symptomatic presentations are very rare. If at all they are symptomatic, if it's a severe disease, they are going to present with syncope and sudden death. Syncope and sudden death. So this is due to development of ventricular tachyarrhythmias. Okay, this is due to ventricular tachycardia, ventricular arrhythmias. Second, they can present with heart failure. Okay. So how will you treat this heart failure? It's very important. You cannot use the routine treatment. Diuretics is going to reduce the preload and increase obstruction. Worsen it. So don't use. So what will be the first line treatment? First line treatment will be beta blockers. And alternative will be non-dihydropyridine calcium channel blockers like verapamil diltiazem. Alternative. But first line is always beta blockers. Only if there is contraindication beta blocker, use verapamil or diltiazem. Non-dihydropyridine calcium channel blockers. Second, okay, add-on therapy. Second line therapy. Add a drug called disopyramide. If the patient is still having symptoms, okay, if the patient is still symptomatic, add a drug called as disopyramide. Even this is an exam question. Disopyramide is a class 1A antiarrhythmic drug. You all know, isn't it? Class 1A, procainamide, disopyramide, quinidine in Vaughan-Williams classification. Class 1B, lignocaine, phenytoin, mexiladine. Class 1C, flecainide, propofenone, moxazine. Class 2, all beta blockers except sotalol. Class 3, ibutylate, dofetilide, amiodarone, dronidone, sotalol, and vernaculant. Class 4, non-dihydropyridine calcium channel blockers like verapamil diltiazem. Class 5, miscellaneous drugs, digoxin, magnesium sulfate, ivabradine, and your sometimes potassium. So all these things are antiarrhythmic drugs, miscellaneous drugs in class 5. So these are the Vaughan-Williams classification. In that disopyramide, class 1A drug can be used. It's a strong negatively inotropic agent like beta blocker. That's why it can be used in patients with HCM, because whenever you reduce the contractility in HCM and reduce the force of contraction, reduce the amount of heart rate, the heart will feel better, preload will increase, so obstruction will come down. Contractility reduces, obstruction will come down. So that's why these drugs are better drugs. So remember, if still the patient is symptomatic, even after adding disopyramide, if still the patient is symptomatic, what are you going to do? You're going to see the level of obstruction. Okay? If the gradient, LVOT gradient is more than 50, you can do septal reduction therapies. As far as I know, SRT stands for Sachin Ramesh Tendulkar, but here it stands for septal reduction therapies. If the gradient is more than 50 millimeters of mercury in echocardiogram. What are the septal reduction therapies? One is alcohol septal ablation. Alcohol septal ablation. This will be usually tried in patients who are not eligible for surgery, unfit for surgery, like old patients. And second is septal myomectomy. Septal myomectomy. Septal myomectomy. Okay, septal myomectomy. And I forgot adenosine. Adenosine also will come under class 5. Okay, miscellaneous drugs. Okay, septal myomectomy. This is for young patients who are fit. Septal myomectomy. So this is septal reduction therapy. This is how you treat HOC. And I'm not talking pathology. So many people say myocyte disarray or helter-skelter myocyte disarray. All these things are fine, but I'm not going to discuss that. That's not a very high-yielding information for exams. Going to the next question. So, 8th question. 70-year-old man presenting with history of hypertension, diabetes, dyslipidemia is brought to the emergency because of reports of palpitations and dizziness. ECG is ordered and is shown in the image. His temperature is 36.8 degrees Celsius. Pulse rate is 106. Respiratory rate is 18. Okay, BP is 84/46 millimeters of mercury. SpO2 is 92% room air. What is the next step? Look at this ECG. What you are seeing in the ECG? You are seeing, first of all, all you need to know is whether it's a narrow complex or a wide complex tachycardia. Patient is having a narrow complex tachycardia. Quick review. It's a narrow complex for sure. Next is to know whether the patient is having a regular rhythm or irregular rhythm. Look at the rhythm. Definitely it's an irregular rhythm without a doubt. So look at the question and say what is the right answer. What is the right answer? So it's an irregular narrow complex tachycardia. The right answer for this question is option D, that is synchronized DC cardioversion, just because the patient is in shock. That's all. The SBP here is less than 90. So the right answer will be synchronized DC cardioversion. Okay. So how will you treat a tachyarrhythmia in an emergency? That is a very common question in exam. So many times we have discussed that. So whenever a patient is presenting with tachycardia, look at a pulse. In the ECG, if you see a tachyarrhythmia, pulse is there or not there. That's very important. If the pulse is not there, it is a cardiac arrest. Proceed to ACLS protocol. Or if you don't have shocking device and if you don't know what rhythm is, proceed to CPR, ACLS, cardiac arrest algorithm. That's it. Proceed to ACLS cardiac arrest algorithm, depending on what rhythm it is. If you don't have any shocking device, start CPR immediately if you don't have a pulse. So if the patient has a pulse, tachyarrhythmia with a pulse, then look at stability of the patient, whether the patient is stable or not. That's the question you're going to ask. Whether the patient is stable or unstable. The most important sign of stability is systolic BP of more than 90. Okay, here it should be yes, right? So I'm writing wrongly. Okay, if the patient is stable means the systolic BP should be more than 90. Okay, if the patient is having a SBP of less than 90, unstable, synchronized DC cardioversion. Synchronized DC cardioversion. So somebody is asking what is synchronized and unsynchronized. Synchronized is very simple. In the device, you're going to just have a button called as sync button. That's it. Just press the sync button. That's all. What the device is going to do, it's going to give shock at the peak of the R wave. Okay, it's going to time the shock in such a way at the peak of the R wave. That is very important because in certain tachyarrhythmias, if you by mistake shock during the T wave, especially during the beginning of the T wave, that will result in something called R on T phenomenon, and that can result in degeneration of the pre-existing tachycardia to more worse tachyarrhythmias like VF and torsades. So that's why you should avoid R on T phenomenon. So that's the reason why the shock should always fall on the peak of the R wave in most circumstances. That's called as synchronized DC cardioversion. In some situations, you need not synchronize, like cardiac arrest situations. If you know it's a shockable rhythm, need not synchronize. Just press, no need to press the sync button. Unsynchronize, that's called as defibrillation. Okay, alright. So if the patient is stable, yes, then you can proceed to drug. See the QRS width, whether the patient is having a narrow complex tachycardia or wide complex tachycardia. Remember, the definition is QRS width of less than 120 milliseconds or more than 120 milliseconds. In children, it is 90 milliseconds, 0.09. But in adults, it is 120. If it's a wide complex tachycardia, you're going to start with antiarrhythmic drug infusions. ACLS guidelines recommend 3 drugs: amiodarone, sotalol, and prokinemin. Okay, amiodarone, sotalol, and prokinemin. Okay, 3 drugs. But the problem is all these 3 drugs can increase the QT interval. Amiodarone, class 3 drug, potassium channel blocker, increase QT interval. Sotalol, class 3, potassium channel blocker, increase QT interval. And prokinemin also is a class 1A drug that also has some potassium channel blocking property, so it can also increase the QT. So that's why in patients with long QT related tachyarrhythmias, it's better to avoid these drugs. Like for example, if you're sure it's a polymorphic VT and torsades, it's better to use magnesium sulfate in this situation alone. Apart from that, ACLS recommends these 3 drugs only in a routine wide complex tachycardia. If it's a narrow complex tachycardia, see whether the patient is having regular rhythm or whether the patient is having irregular rhythm. If the patient is having regular rhythm, then first try vagal maneuvers like Valsalva or carotid sinus massage. If it doesn't work, if the patient is not responding, then proceed to adenosine. Okay, adenosine. Then proceed to adenosine. So you know what is the dose of adenosine? 6 plus 12 plus 12, and the duration of action of adenosine is hardly 10 seconds. So you have to give adenosine by a rapid IV push. So you have to augment with the saline bolus. That's very important. In case if it's a irregular, the first dose they will ask you in exam, it is 6 milligram quite often. So if it's an irregular rhythm, then you can use beta blockers, or alternative to beta blockers will be non-dihydropyridine calcium channel blocker like verapamil or diltiazem. But beta blockers is better. Okay, beta blockers is better. First choice. Alternative will be non-dihydropyridine calcium channel blocker. But remember, please understand, in irregular rhythms, adenosine should not be used. It's contraindicated due to various reasons. No adenosine if the rhythm is irregular. Only in regular rhythms you can use adenosine. In case if they ask you if adenosine is contraindicated, so what will be the important contraindication for adenosine? Bronchospasm. Remember, if adenosine is contraindicated because of bronchospasm, even beta blockers will be contraindicated. So there also you can use NDHPs. So if they say that bronchospasm prevents you from using adenosine, then you have to use NDHPs only, verapamil or diltiazem. If the patient is not receiving adenosine because it's not available, then alternative will be beta blocker. But remember, adenosine and beta blockers share the same contraindication, that is bronchospasm. You have to be clear about that. So this is the algorithm for managing a tachyarrhythmia in exam. Very important. The right answer for this question is option D, that is DC cardioversion. What about this question? Question 9. A 52-year-old man presents for muscle checkup. His BP is 148/96 millimeters of mercury and has lower urinary tract symptoms. The examination is normal except for an enlarged smooth prostate. Laboratory studies were done and it is normal. What is the most appropriate next step in the management? In exam, remember, most of the times, trust me, they won't ask you the guidelines. I've never seen somebody asking you the guidelines. They will ask you only the rationale behind those recommendations. So don't get confused whether you wanted to, don't get confused whether you wanted to study a ACCHA guideline or ESC guideline or ISH guideline. There are plenty of guidelines available in the world. But as far as I know, in an exam like NEET PG or probably FMG, the rationale is more important and relevant. They won't give the guideline. That is usual. They won't ask like according to ESC, what you will do. According to ACCHA, what are you going to do? So don't worry about that. They'll ask you the rationale. So here the answer is very simple. The patient is having hypertension. There's no doubt about that. BP is more than 140/90 and the patient is having benign prostatic hyperplasia. So very clearly the choice of the drug will be prazosin. That's all. Remember, in hypertension, irrespective of whatever drug you use, irrespective of whatever drug you use, it doesn't matter. You have to reduce the BP. That's the most important point in hypertension. So there is a rule, remember, for every 20 millimeter increase in systolic blood pressure and 10 millimeter increase in diastolic BP, above a BP of 115/75. So let us assume a baseline BP of 115/75, and above that, for every 20 increase in systolic and 10 increase in diastolic, the cardiovascular mortality increases by 2 times, which means patients are going to die 2 times more for every 20/10 increase. This is a very important number because guidelines clearly say, any guideline if you take, the primary issue is to reduce the BP. That's the most important, because even if you can achieve the BP reduction by at least 20/10, the cardiovascular mortality will become half. Just reduce 20/10, cardiovascular mortality will reduce half. 50% it will reduce. Reduce by 40/20, cardiovascular mortality will reduce by 4 times. That's why the BP control is more important. The choice of drugs will depend on what is the patient's comorbid status. So to start with, you can say A plus C, A plus D, C plus D, whatever combination you want. But the choice always depends on the patient's underlying comorbid status. So what are the comorbid status? If the patient is having left ventricular hypertrophy, I'm going to choose a ARB or probably an AC inhibitor. That's what I'm going to choose. Because in one trial called as LIFE trial, it's proved that ARBs cause regression of left ventricular hypertrophy. That's why ARBs are AC inhibitors. Anyone you can use. If the patient is having heart failure and having hypertension, obviously, simple, straightforward. Currently, we prefer RNAs as the first choice. That is angiotensin receptor neprilysin inhibitors, first choice. Or alternative, if the patient is not affordable for RNA or your institution is not having RNA, sacubitril valsartan, then use ACE inhibitors or ARBs. Okay, A just stands for ACE inhibitors or ARBs. Let us be simple, ACE inhibitors or ARBs. What are the alternative drugs? You can use even beta blockers, but remember only 3 beta blockers are proven to be effective in patients with heart failure. Okay, one is metoprolol, second is carvedilol, third one is going to be bisoprolol. Only 3 drugs, metoprolol, bisoprolol and carvedilol. Only 3 drugs are considered to be better in heart failure patients. And third is MRAs, mineralocorticoid receptor antagonists, or simply in your terms potassium sparing diuretics or aldosterone antagonists. What are the 2 drugs? We have spironolactone and we have eplerenone. Any one you can use. Both have same effect only. No difference. Remember, RNA is always better than ACE inhibitors or ARBs in heart failure. But spironolactone and eplerenone are similar to each other. And ACE inhibitors and ARBs are also have equal efficacy. But RNAs are always better compared to ACE inhibitors or ARBs. Plus or minus, you can use even loop diuretics. Even loop diuretics, if the patient is congested, high JVP, edema, ascites, use loop diuretics. Furosemide, even that can be used. But the first 3 drugs are very, very important. So this will be the choice because all these drugs can reduce blood pressure in a patient with heart failure. Third, what about myocardial infarction? MI, of course, first choice will be beta blockers. There is no doubt about that. Because beta blockers in MI, in myocardial infarction, beta blockers are going to reduce the infarct expansion because their negative inotropic agents reduce the oxygen consumption and they can reduce the risk of ventricular arrhythmias also, reduce the risk of ventricular tachyarrhythmias also. Okay, like VTVF, because the most important cause of death in acute MI is ventricular arrhythmias. Beta blockers will reduce the risk of that also. Okay, number 4. What are you going to do if the patient is having chronic stable angina, that is stable ischemic heart disease, that is chronic stable angina, not acute MI. What are you going to use? Beta blockers are the first choice because they reduce angina also and they're going to help in hypertension also. And second choice will be NDHPs. Alternatives to beta blockers will be you can use verapamil or diltiazem. NDHPs also. Dilip Kumar is asking CCBs in heart failure. No, we don't use CCBs in heart failure. I'll tell about that later on. CCBs have no benefit in heart failure. No survival benefit. That's why. Here alternative is NDHPs, verapamil, diltiazem. Okay, plus or minus you can use nitrates also because they can reduce the BP to some extent. Plus at the same time they can reduce angina also. Number 5, what is the other situation? Patients are having CKD, chronic kidney disease. That's a very important point because it's been asked 2 times in NEET exam already. So how will you choose an antihypertensive in CKD patients? It depends. See, first of all, where the patient is having proteinuria or not. That's very important. Proteinuria or not. If the patient is having significant proteinuria, then ACE inhibitors or ARBs will be the first choice. If the patient is not having significant proteinuria, then look at edema. If the patient is having significant edema, then diuretics will be the better choice. Okay, if the patient is not having significant edema, then again ACE inhibitors or ARBs will be the better choice. What kind of diuretics you can choose in CKD? You can choose loop diuretics or you can choose thiazide diuretics as well. Remember, thiazide diuretics are as effective as your loop diuretics. There are 2 types of thiazide diuretics. You know, thiazide-like diuretics and thiazide-type diuretics. So thiazide type diuretics we don't prefer. That is hydrochlorothiazide. That has a lot of side effects and it's not effective in CKD. I'll repeat, thiazide type diuretics like hydrochlorothiazide are not effective in CKD. But thiazide like diuretics like chlorthalidone, metalazone, indapamide, they are having good penetration to the kidney even if the GFR is low. That's why you have to prefer thiazide like diuretics like chlorthalidone, metalazone or indapamide in patients with CKD. Alright. So then what about patients with benign prostatic hyperplasia? It's very simple, straightforward. I'm going to use alpha blockers because that has double effect in both BPH and hypertension. What is the drug I'm going to use in migraine patients? In migraine, I'm going to use beta blockers. Okay, beta blockers because that's going to act as a prophylaxis for migraine and it's going to act as a treatment for hypertension also. What I'm going to use in aortic aneurysm? Aortic aneurysm, beta blockers again. That's the first choice. Why? Because beta blockers reduce the cardiac contractility, force of contraction, and it's going to be negatively inotropic. So we're going to reduce the force of contraction, the amount of pressure on the wall of the aorta will be less. That's why. That's considered to be the better option. If the patient is having Marfan syndrome, specifically Marfan syndrome, then you can use ARB also. This is an old guideline actually, but still maybe they might be asking because it's given in old textbooks. Currently, one trial has disproved it, but in Marfan syndrome, the main problem is fibrillin-1 gene mutation. Because of fibrillin-1 gene mutation, there will be upregulation of TGF-beta. And ARB can actually cause downregulation of TGF-beta, which is very much beneficial in Marfan syndrome. That's why some trials say that Marfan syndrome ARBs are better. And that's it. So these are the most important strategies. Okay, so depending on the comorbid condition, you can use whatever drug you want. So this is what they will ask in exam, not what is the first choice, what is the second choice, who's going to ask that? I don't think they will be asking you anyway. But in case if you want to know what is the standard practice, standard guideline, okay, suppose if the patient is having no comorbidity, so okay, no comorbidity, don't use beta blocker, that's number one. No comorbidity, don't use beta blocker. So what are you going to use then? So step one, generally we prefer something called as A plus C at a low dose, ACE inhibitor or ARB, ACE inhibitor or ARB at a lower dose, at half dose. If the BP is still not within your target, then you can use the same A plus C but at a full dose. Full dose, okay? What about step 3? Step 3, you can add a diuretic, A plus C plus D. Okay, this diuretic generally a thiazide diuretic. Usually we add a thiazide diuretic, especially a thiazide like diuretic. Thiazide like diuretic like chlorthalidone or indapamide. In step 4, remember when you enter step 4, it means you are entering a stage of resistant hypertension. Now it becomes resistant hypertension. So what is the definition of resistant hypertension? If the BP is off target despite adding 3 drugs. BP is not controlled despite adding 3 drugs and 1 drug should be a diuretic, okay, at least. So that is the definition of resistant hypertension. So step 4, you have to work up. Definitely you have to work up. You have to do the workup. So why the patient is having resistant hypertension? If you don't find out the cause of resistant hypertension, or if you don't have the investigation backup to evaluate the patient, or if the economic status is poor, then optionally you can add spironolactone at a dose of 25 to 50 milligram per day. That's what the guidelines are saying. That's an optional thing. You can add spironolactone. Consider adding spironolactone if you want. But remember, before deeming the patient as resistant hypertension, ensure compliance. The most important reason for the BP not getting controlled is non-compliance. So ensure compliance and make sure that the patient is on a low sodium diet, because whenever the patient is taking too much of sodium, the BP will not get controlled. So ensure the patient is on low sodium diet, ensure the patient is getting diuretic, and ensure the patient is taking the drugs correctly. So then you make a diagnosis of resistant hypertension. Then optionally you can add spironolactone, or probably you can work up and look for causes of secondary hypertension also, like renal artery stenosis. Right answer for this question is option D. It's a very simple and straightforward question. So what about question number 10? You have a 74-year-old man with a history of dyslipidemia, hypertension and aortic sclerosis. That is expected in a patient with such an age. Presence to the ER with chest pain. The chest pain is similar to the angina attacks in the past. Remember, this is a very important history. If the anginal attacks are similar to the angina attacks in the past, it is angina only. It is an acute event. That's all. He took 3 nitroglycerin tablets with some relief, but not complete relief. That's an important point. In the ER, he has been given aspirin, he has been given metoprolol, he has been given morphine and placed on nasal oxygen ECG monitoring. On examination, patient is diaphoretic. Another important clue for ACS. and patients appear to be uncomfortable. His vitals are stable and cardiac enzymes were normal. ECG on admission is shown. What is the likely diagnosis? What are you seeing in the ECG? Okay, ECG is normal. So there is nothing. You don't see ST elevations. You don't see any other changes like ST depression or TY inversion also. ECG is fairly looking normal. So don't look at V1. V1 some ST depression like features are there. Some TY inversion like is there. That is normal. In AVR also some minimal TY inversion is normal. Because in AVR usually TYs will be inverted only. There's no doubt. Okay, so that's all normal thing. So it's a completely normal ECG. There is no change. So a patient whose presentation is compatible with ACS but having a normal ECG, normal enzymes. At present, what is the diagnosis? Simple, unstable angina. We discussed already. Even though currently we don't make the diagnosis of unstable angina, but in exam still you will get a lot of questions on unstable angina. So the exact take-home message from this question is the fact that a normal initial ECG and a normal cardiac enzymes does not rule out ACS. I'll repeat, a normal initial ECG and a normal cardiac enzymes at presentation does not rule out ACS. Still it can be. That is the reason why you need to always consider doing a serial ECG. Okay, repeat ECG. And you have to do serial biomarkers. Serial biomarker testing, which means serial troponin assays are very, very important to look for changes because ACS is a dynamic situation. Initially, everything can be normal, but later on, you can get some dynamic new changes. That's why you look for it. Serial ECG and serial biomarkers. We have discussed so many times. So what is the emergency treatment? When you are suspecting ACS, you need to start the initial management. This is what they will be asking in exam. So what is the initial treatment of ACS? So we know the mnemonic is going to be MONA BC. Okay, that's the mnemonic. So M stands for morphine. Okay. O stands for oxygen. N stands for nitrates. Usually you give a short-acting drug like nitroglycerin. A stands for antiplatelet agents. Antiplatelet agents where you'll give aspirin plus or minus an optional P2Y12 inhibitor. So I think we have discussed this already in one of the previous YouTube session. That's why I'm not telling it right now. So what are the three P2Y12 inhibitors that we have? So we have clopidogrel, we have prasugrel, and we have ticagrelor. The choice will depend on so many things. I'm not going to discuss right now because we don't have time as of now. So and B stands for beta blockers. Beta blockers, and you need to know the standard beta blocker contraindications. What are the beta blocker contraindications? Number one, if the patient is having hemodynamic instability, I'm not going to use a negative inotropic drug like beta blocker. Second, if the patient is having low heart rate, if the patient is having low hemodynamic instability means low BP, I'm not going to use. If the patient is having acute heart failure, I'm not going to use. If the patient is having PR interval of more than 0.24 seconds, I'm not going to use. If the patient is having a second degree or a third degree AV block, I'm not going to use beta blocker. Specifically in MI, apart and severe reactive airways disease, number 6, I forgot that. So severe reactive airways disease like bronchial asthma and COPD, I'm not going to use. Finally, last but not the least, we can say that in MI, there are some specific contraindications. Like for example, if the patient is having a SBP of less than 120 or a heart rate of more than 110, we should not use because these are indicative of pre-shock state. This is indicative of pre-shock. So because of the sympathetic response, the patient's heart rate is high and just BP will be maintained like in the borderline, cat on the wall scenario. If you give beta blocker and reduce the heart rate, the patient will collapse, enter into a frank shock. So, or if the patient is having Killip class 2 and above, Killip class 2 and above, okay. That's also a very important contraindication in MI. So, you know Killip class 1, right? Killip class 1 means no heart failure. Patient is not having any signs of heart failure. Killip class 2 means some heart failure will be there, which means patients will have S3, patients will have jugular venous distension, and patients will have crepitations, but limited to the base of the heart. Class 3 means patient will have frank pulmonary edema, which means the entire chest will be loaded with crepitations. Class 4 means patient is in cardiogenic shock. Okay, so anything Killip class 2 and above, I'm not going to use beta blockers for sure. Okay, so these are the important beta blocker contraindications. C stands for anticoagulation. Anticoagulation or coagulation pathway inhibitors. So what are the 4 anticoagulants that we use in the setting of ACS? One is unfractionaparin. Second is low molecular heparin. The most common example is enoxaparin. Third is fondaparinux. And fourth is bivalirudin. In that, commonly we use commonly we use these two drugs, lomodaparin or unfractionaparin. Each and everything has its unique advantages, which again I'm not going to discuss right now. Unfractionaparin, one important thing is it's safe in renal failure. It's safe in renal failure. Okay, because dose need not be adjusted at all because it is metabolized by reticuloendothelial system. And second point, you may know it's preferred in patients if you're doing any procedure in the next 2 or 24 hours. So in STEMI, it's better. STEMI plus if you are planning a PCI, it is better. So unfractionaparin is better because it is reversible, because you have a good antidote. So what is the antidote? Antidote is protamine sulfate. It's a cheap antidote. It's quickly available and can reverse the effect very fast in the evidence of bleeding. So that's why it's preferred whenever you are planning some procedure. Not PCI, any surgery also, if you are planning in the next few hours, unfractionaparin will be the preferred anticoagulation. But the one problem with unfractionaparin is it has a little high risk of, not so much, but slightly higher risk of heparin-induced thrombocytopenia. So what we are doing in lomodaparin? So in lomodaparin, when you choose, enoxaparin will be the usual drug. So when you are going to choose lomodaparin like enoxaparin, whenever you are not planning a procedure, not planning PCI, it could be STEMI or it could be NSTEMI, unstable angina. If you are not planning for angiogram or PCI, you can prefer enoxaparin. Very commonly, NSTEMI patients only will not receive PCI according to the traditional thinking. But right now I told you, anyone with elevated troponin, you're going to prefer coronary angiogram. But the traditional thinking is NSTEMI, unstable angina patients generally will not go for a PCI immediately. So that's why in those patients, enoxaparin will be a better choice if you're not planning for a PCI, especially in the next 24 to 48 hours. So what about the risk of it? Risk of it is still there. There is reduced risk of heparin-induced thrombocytopenia, but still not zero. Not zero risk, still there. Okay, still the risk is there, but lesser risk compared to unfractionated, but the risk is still there. But if you're not planning for PCI, in the next 24 to 48 hours, this will be a better choice. And it is not safe in renal failure. You have to reduce the dose in patients with renal failure. It's not safe. And you don't have a good antidote, honestly speaking. You don't have a good antidote for lomodaparin. Andexanet alpha can be used. Protamine sulfate also can be used, but both are not that effective. But best is actually andexanet alpha if you wanted to reverse lomodaparin, which is not available in most centers. Fondaparinux is one of the longest acting drugs. Okay, it's an indirect factor 10 inhibitor. It's derived from heparin only, but contains only the active pentasaccharide. Very long acting drug. So reversal is very, very difficult. Only drug that can reverse its effect is andexanet alpha. Protamine sulfate has no effect. At least some effect of protamine sulfate can be expected in enoxaparin, but fondaparinux no effect whatsoever. Okay, protamine sulfate is useless. There is no reversal agent. If you want to use only andexanet alpha. So it will be used only when you are not planning for a PCI. Not planning for PCI. Okay, in the next 24 48 hours or whatever it is. Plus, if the patient is having history of heparin-induced thrombocytopenia, because this is not going to cause heparin-induced thrombocytopenia. There is zero risk. So, zero risk. No risk of heparin-induced thrombocytopenia. When you choose bivalirudin exam, you are going to choose bivalirudin exam whenever you are planning for a PCI. Planning for PCI in a short while, in the next 2 hours or in the next 24 hours. Plus, if the patient is having history of heparin-induced thrombocytopenia, there is no other option. It's better to use bivalirudin, but it will be used inside the cath lab. So, if the patient is already having a HIT history, you cannot use UFH or LMWH like enoxaparin. What you can do is during PC, you can use bivalirudin infusions because this also has a zero risk. No risk of heparin-induced thrombocytopenia. So, both UFH and LMWH has a risk of HIT, but fondaparinux bivalirudin doesn't have a risk of it. And another point is fondaparinux is unsafe in renal failure. You need to definitely reduce the dose, or it's better to avoid in patients with renal dysfunction in renal failure. So oral drugs we don't use in ACS. Don't use oral drugs in ACS. So this is what you're going to do in patients with ACS as an initial management. Most of the questions will be lingering around your initial management only. What about question number 11? A 72-year-old man presented 2 days ago to the emergency room with chest pain and was diagnosed and treated for anterior myocardial infarction. On the morning of his second hospital day, his pulse rate is 60, which means he is bradycardic, respiratory rate is 16, BP is normal 124/76, temperature is 36.7 degrees Celsius, SpO2 is 99, a routine ECG is obtained. What is the most appropriate treatment? So look at the ECG and make a diagnosis. So what is the diagnosis on seeing the ECG? What is the diagnosis that you're going to make? First, I asked you about the diagnosis. So you need to make the diagnosis, right? Yeah, post MI only. The diagnosis actually Mobitz 2. Mobitz 2 is the diagnosis. So why it is Mobitz 2? First of all, you can see that there is a definite pause. So you can see that the patient is having a P wave, but it is not conducted. So whenever you have a P wave which is not conducted, it is Mobitz only. And in that situation, look at the PR interval. So PR interval is constant here. PR interval is not changing. PR interval is constant. If at all PR interval is constant, it is Mobitz type 2. In Mobitz type 1, PR interval will be varying. It will be increasing till the missed beat occurs. In Mobitz type 2, the PR interval will be constant. So here the PR interval is constant. So it is basically Mobitz type 2 block. So remember, it's not an acute tachyarrhythmia. First of all, it's not an acute tachyarrhythmia. It's a chronic, in the sense like it is occurring after a myocardial infarction, that to 2 days after myocardial infarction. So it's not due to ischemia. Remember, any bradyarrhythmia in the first 24 to 48 hours usually will be due to ischemia itself. But clearly they have given 2 days later, after 2 days, and is already treated for the ischemia. So now the reason for this arrhythmia is not ischemia. It is due to some permanent damage to the fiber, conducting fibers. If it occurring within the first 24 to 48 hours, you can deem it as what? Ischemia related injury. So if you do reperfusion, the things might reverse. But after for 24 to 48 hours, especially after 48 hours, if it is still, any arrhythmia that is still persisting after 48 hours, brady or tachy, it must be due to some permanent issue, which means some irreversible damage. Which means in this case, there is an irreversible damage to the conducting fibers. That's why my answer will be permanent pacemaker. Okay, permanent pacemaker. So atropine IV will be used only in acute symptomatic bradies. So let us assume a patient is presenting with acute bradycardia. Okay, acute bradyarrhythmia. And next step in acute bradyarrhythmia is to see whether the patient is unstable or not. Unstable or not. If the patient is not unstable, okay, patient is not unstable, which means especially if the SBP is more than 90 millimeters of mercury, then I'm going to just observe in any acute brady. Just observe, don't do anything. If the patient is not unstable, okay, if the patient is not unstable, which means patient is unstable. I mean, patient is unstable. SBP is less than 90. What are you going to do? SBP is less than 90. Then immediately you have to start treatment. First treatment is always atropine. And the initial doses, first dose of atropine will be 0.5 milligram, and you can give a total maximum dose of 3 milligram. And if the atropine doses are not working, not responding, you have given up to 3 milligram, but it's not working. What are you going to do next? You have to go for a temporary pacing option. Temporary pacing. Temporary pacing option. Initially, you can try a transcutaneous pacing because it's an emergency. So you don't have time to put a center line and all. So transcutaneous is fine. Just putting the leads on the chest, you can start pacing the heart, but it's a little painful process. But in emergency, you can do it. In case if the after some time later on, you have to convert that to transvenous pacing. You have to introduce a central line, and then through that you have to thread the wire into the right ventricle. You have to pace from the right ventricle. So transvenous pacing. Of course, you have single chamber and double chamber pacing, which is beyond the scope of the current discussion. But later on, you can do transvenous pacing. If you don't have the pacing facility, alternative to pacing will be chronotropic drugs like dopamine or adrenaline. So remember, noradrenaline is not a very good chronotropic drug. I think you got a question in FMG exam also yesterday. So they asked one question on noradrenaline. What the graph they have given in noradrenaline? Noradrenaline actually tends to reduce the heart rate in experimental animals, even though that doesn't happen in most patients in ICUs. But noradrenaline is not a good agent to increase the heart rate. It increases the BP, but it doesn't increase the heart rate. In fact, in experimental models, it reduces the heart rate. So don't use noradrenaline. You're going to use either dopamine or adrenaline, which are very good chronotropic drugs. These are things we are going to use, especially if the patient is in shock. Okay, so don't say dobutamine. Dobutamine cannot be used in shock patients. Okay, I told you already. So vasodilating anadrol never can be used in shock. So these are the options for acute bradyarrhythmia. So remember, observation could be the case if the patient is completely asymptomatic and having an acute bradyarrhythmia. Atropine should be given only if the patient is unstable and having an acute bradyarrhythmia. Patient is absolutely stable, no problem. Carotid massage we don't do generally. Okay, carotid massage indicated for a tachyarrhythmia, not a bradyarrhythmia. If there are any students who have read Harrison, who is going to tell me in which bradyarrhythmia I can use carotid sinus massage, not for diagnosis, for treatment. In which bradyarrhythmia I can use carotid sinus massage? Any student who has studied Harrison definitely should be able to say this. In which bradyarrhythmia? It's a bradycardia where I can use a carotid sinus massage. It's an AV block where I can use a carotid sinus massage. I've given a clue. Isoprenaline also given for infusion. Remember, Dr. Abhijit, isoprenaline is a phosphodiesterase inhibitor. I mean, it's a pure beta agonist. Whenever you give a pure beta agonist, it's going to stimulate the beta 2 receptors, which can cause vasodilation and it's going to reduce the BP. If the patient is stable, normal BP, okay, then you can use isoprenaline to increase the heart rate. But if the patient is in shock, low BP, how can you use isoprenaline? That's going to cause vasodilation through beta 2 and it's going to reduce the BP. So don't do that. Okay, third degree, no. Actually, it's Mobitz 2. Mobitz 2, carotid massage or any vagal maneuver. Okay. Carotid massage especially can be effective. Can actually reduce the bradyarrhythmia. There are a lot of reasons for that. But in Mobitz type 1, carotid massage or any vagal maneuver will worsen the block. It will worsen. Which means here it will be improve. It will improve. Sometimes it can improve the Mobitz 2 block. So that is the reason. I mean, obviously, this question is framed on that only, assuming that people have read Harrison. So basically, carotid sinus massage can be used for patients with Mobitz 2. Okay, that can improve the Mobitz 2, but it's only acutely. For acute bradyarrhythmias, just to, I mean, it's an experimental thing, so you can try, but otherwise, we are not going to try in such a case where the patient is having a kind of a chronic bradycardia where permanent pacemaker will be the preferred choice. So understand, what are the indications for permanent pacemaker? The most important indications, permanent pacemaker, that you need to know for exams. PPM, permanent pacemaker for exams. Number 1, okay, any symptomatic bradycardia. Any chronic symptomatic brady is an indication for permanent pacemaker. Even if it's a sinus bradycardia, you need to introduce a permanent, any symptomatic bradycardia. Second, even if the patient is asymptomatic, you can introduce a permanent pacemaker if the patient is asymptomatic, plus if the patient is having a second degree AV block. Okay, if the patient is having asymptomatic plus having a third degree AV block, you can use. Or if the patient is having a second degree AV block. Okay, even Mobitz 2 is a very important indication. Even if the patient is having no symptoms also, if the patient is having a second degree AV block, especially Mobitz 2, second degree AV block Mobitz 2, because Mobitz 2 is more dangerous than Mobitz 1. Plus, if the patient is having a white QRS. Even if the patient is asymptomatic, okay, even if the patient is asymptomatic, having a second degree Mobitz 2 with a white QRS, definitely you have to introduce a permanent pacemaker. So look at our patient. Our patient is having Mobitz 2 and having a white QRS or narrow QRS. You can look at the QRS and say, white QRS or narrow QRS. Somebody is asking Brugada. Brugada we use ICD, man. We don't use pacemaker. I mean, you can use in selected patients with LQTS syndrome. I mean, that's a different choice, but usually Brugada is like ICD, no? That's what you're going to answer in exams as a first choice. So is it white QRS or narrow QRS? It's a white QRS, right? Patient is having white QRS. You can see very clearly it's a white QRS. So that's why this patient is a perfect candidate. Mobitz 2, okay, asymptomatic, but still having a white QRS. Definitely you can opt for a permanent pacemaker. Even if it's a narrow QRS, you can use, but it's a class 2. Remember, white QRS is class 1 indication. Or if the patient is having narrow QRS, that becomes a class 2 indication though, but still you can use. Mobitz 2 is always dangerous. Mobitz 2 is always dangerous. Third, if the patient is having no symptoms, but if the patient is having exercise-induced second or third degree AV block, exercise-induced second or third degree AV block. It could be Mobitz 1 or 2, doesn't matter. Here, there is nothing like that. Mobitz 1 or Mobitz 2, it doesn't matter. Excise induced second degree or third degree AV block. Even if the patient is asymptomatic, you have to introduce a permanent pacemaker. And any chronic bradycardia with a heart rate of less than 40 is a definite indication. This is also something that you need to know. And finally, patients who are having carotid sinus hypersensitivity. So what will be the clue for carotid sinus hypersensitivity in exam? Whenever the patient develops syncope when they are shaving, especially these will be males, whenever they develop syncope during shaving or whenever they put tight collars. Okay, that time, if that history is given, it indicates carotid sinus hypersensitivity. So if the patient is having carotid sinus hypersensitivity with a flat line, documented asystole that lasts for more than 3 seconds, okay, or if it's more than 6 seconds, okay. So if the patient is symptomatic, then you can take 3 seconds as the cutoff. If the patient is asymptomatic, then you can take 6 seconds as the cutoff. So asystole for more than 3 or 6 seconds, depending on the symptoms, that's an indication for this thing. Or anyone with sick sinus syndrome. Sick sinus syndrome becomes a straightforward indication for a pacemaker. There is no doubt about that. And congenital complete heart block. Congenital complete heart block, especially if the patient is having neuromuscular disease. Neuromuscular disease. This is already a question in one of the NEET exams. I think 2015 they asked this question. So congenital complete heart block with a neuromuscular disease like Duchenne muscular dystrophy, Kearns-Sayre syndrome. So this is a very important indication, congenital complete heart block. So if somebody asks you what is the most common cause of congenital complete heart block, what should you answer? You should answer neonatal lupus. I'll repeat, somebody asks you what is the most common cause of complete heart block, answer will be neonatal lupus because of anti-Rho antibodies. So some important indications I've told you. There are plenty of indications. These are the important indications of permanent pacemaker. Our patient perfectly fits into the indication of permanent pacing. Okay. A patient collapsed and was brought to the casualty with no proper history. What is the next step? So collapsed, brought to the casualty with no proper history. So what are you going to do? Very simple. So this is something we have discussed already so many times. Patient is coming up with a collapse. I think we have discussed already in our previous FMG discussions itself, the revision YouTube sessions itself. Patient is having a collapse. First, you have to ensure scene safety. This is based on the BLS, basic life support algorithm. So verify the scene safety first. Then once you verify the scene safety, also simultaneously call for help. Activate the emergency medical services. Okay, any call some ambulance. So then look for the responsiveness. So now we have done all these things, check for responsiveness. If the patient is responsive or not responsive. If the patient is responsive, observe. Just observe the patient till the EMS arrives at your scene. If the patient is non-responsive, then check for pulse and breathing. So if the patient is having a pulse and having a normal respiratory pattern, then just observe, no need to do anything else. If the patient is not having a pulse but not having a normal breathing pattern, or if it's a respiratory arrest, that's called primary respiratory arrest, then just use rescue breaths. What is the ratio of what will be the rescue breaths? Here you're not doing chest compression. So rescue breaths will be given at a rate of 10 per minute. 10 per minute. In pediatric population, it is around 20 to 30 per minute. But in adults, it's 10 per minute, 1 breath in 6 seconds. If the patient is not having pulse, of course, they will not have breathing also. So if the patient is not having a pulse, the carotid pulse, then next step is to start CPR because this is cardiac arrest. This is CPR. You have to follow the ACLS protocol from here on. So CPR, of course, in adults, the chest compression to rescue breath ratio is always 30:2. In pediatric population, depending on the rescuers, if the single rescuer, then it's going to be 30:2. If it's a double rescuer, more than one rescuer means the rescue breath to chest compression ratio is 15:2. In neonatal population, it is 3:1, right? So that's the chest compression to rescue breath ratio. So how to do CPR? I think you would have been already trained. So 2 hands in patients who are adults, just 1 hand if it's a pediatric population. You can use just 2 fingers if the patient is a neonat or an infant. Okay, so according to the algorithm, the right answer for this question is option A, that is checking for responsiveness. So look at this question. Which of the following is the strongest predictor of cardiovascular disease incidence and subsequent mortality due to cardiovascular disease? Is it total cholesterol by HDL, or is it LDL, or is it HSCRP, or is HDL? Remember, whatever may be the case, whenever they talk about a marker and cardiovascular disease, it is always LDL. That's all. Don't get confused on anything. They have done innumerable research on HSCRP. It's a good sensitivity. It has a very high sensitivity and it has a very high negative predictive value, but its specificity is very poor. So high HSCRP doesn't always mean cardiovascular risk. If it's normal, it rules out cardiovascular disease. But high HSCRP doesn't confirm cardiovascular disease. It can be due to other inflammatory conditions also. That's why no HSCRP, even though it's very, very sensitive. HDL is not at all a good marker. Okay, whether you have low HDL or not doesn't matter. Total cholesterol by HDL is only in low resource settings. As an alternative to LDL, you can use TC by HDL ratio. But LDL is the single most important powerful marker of cardiovascular disease. That's why all the targets with regards to statin use will be based on LDL. And how will you calculate LDL? It is based on something called as Friedewald formula. Friedewald formula. So this is called as calculated LDL. So it's very simple. It is total cholesterol minus HDL minus VLDL. So usually we don't do direct VLDL measurements. Instead, triglyceride by 5 will give you the VLDL. 1/5 of triglyceride is going to tell you the VLDL value. So all you need to measure is only 3 values. Total cholesterol, HDL, triglyceride. Just measure these 3, you are going to get VLDL and LDL together. That's called Friedewald formula. So this was calculated LDL. So if you are using Friedewald formula for determining LDL, that is calculated LDL, patient should be in fasting. At least 12 hours of fasting is important. Fasting sample is mandatory. Because if the patient is not in fasting, then triglyceride values will increase. And that will falsely increase the VLDL because we are calculating, not measuring. And if you increase the VLDL according to the formula, the LDL will become falsely low. So if you take a non-fasting sample, LDL levels can be falsely low. So that's wrong. So if you want to use in a non-fasting sample, do direct LDL measurements. Patient is non-fasting means one option is to do direct LDL measurement. Second reason why you want to do a direct LDL is if the triglyceride levels are more than 500. In this situation also, it's better to use a direct LDL measurement. Why? In very high triglycerides, usually our VLDL values again will be very high and LDL values will be falsely low. So that's the reason you measure LDL directly in case if the patient is non-fasting or if that patient's triglyceride is more than 500. Okay, this is very important for example. It is Friedewald formula. And there is another question in exam that has been asked in 2019. When will you do the lipid profile in a patient with MI? Remember, the best time to do lipid profile in a patient with MI is in the first 24 hours. First 24 hours you have to do it in patient with acute MI. After 24 hours, because of catecholamine surge, because it's a stress reaction, the body is under stress. So because of catecholamine surge, after 24 hours, the LDL levels may be falsely low. That's the reason once you miss the initial 24 hours, you can do after 4 weeks only. After 4 weeks only, you can do lipid profile measurements. So if you don't do in the first 24 hours, if you don't do in the first 24 hours, you can do only after 4 weeks or maybe around 28 or 30 days. After that only. That time only the lipid profile will be accurate. But anyway, by that time, many of the patients will have we would have received statins and like they will have a low LDL only. So Zolangsma is asking why LDL is not included in ASCVD or metabolic syndrome. Not included in ASCVD. I don't understand. So in ASCVD it is included. ASCVD risk calculation. Metabolic syndrome it is not included because metabolic syndrome is a totally different disorder. Okay, that is based on obesity and lifestyle. LDL is not a lifestyle marker. Triglyceride and HDL is a lifestyle marker. If your diet is poor or if you are very obese, then triglycerides will increase and HDL will fall. Okay, so that is why we are using only triglyceride and HDL in metabolic syndrome. We are not going to use LDL. LDL is not a lifestyle marker. So coming to question 14, a 51-year-old male presenting with recurrent chest pain 4 days after stemming. The chest pain radiates to the trapezius and worse with deep inspiration. The pain woke him up from sleep and improved slightly after getting up out of bed. Cardiac troponin levels are unchanged and ECG showed again my language is very poor. ECG showed. ECG showed new ST elevations in inferior and lateral leads. What is the likely cause? So clearly this patient is suffering from pericarditis. There is no doubt about that. So this is an acute pericarditis. So why? There are plenty of features to say it's an acute pericarditis. Number one, the pain radiates to the trapezius. That's a very, very important sign of pericarditis. And pain is worse with deep inspiration. It's a pleuritic pain. That also tells you it is a pericarditis. And pain woke him up from sleep, which means during sleep it's increasing, means when lying down the pain is more. And after getting up from bed, which means most of the pericarditis pain will reduce on leaning forward position, right? Pain will reduce on leaning forward. So pain radiating to the trapezius, worsening with deep inspiration, and improving on leaning forward. So all these are classic signs of pericarditis. And cardiac troponin levels are unchanged because it's pericarditis. Why the troponin should increase in a pericardial damage? Only in myocardial damage, troponin will increase. And patient is having new ST elevations though. But usually what will be the type of ST elevation? Saddle ST elevations. In pericarditis, you will have saddle or concave ST elevations. Concave ST elevations. It will not be convex. And most commonly, you will see inferior lateral leads only. Even though it's global. In pericarditis, you will see global ST elevations or multifocal ST elevations. Generally, most common situation, inferior lateral leads only, you will see ST elevation. What is the likely cause? Of course, it's pericarditis. But it's early or late. It's early pericarditis. Our right answer is B. So why early pericarditis? Because post-MI pericarditis or post-TEMI especially, post-TEMI pericarditis is of two types. One is early pericarditis and second is late pericarditis. Early pericarditis tends to occur in the first 1 week itself. That's the timing is very, very important. First 1 week. Late pericarditis tend to occur after 1 week. Typically in the time frame of 2 weeks to 2 months. Early pericarditis is just due to spilling of inflammation from the nearby ischemic area or necrosed area or infarct area. Late pericarditis is basically autoimmune in nature. That's why it's called as Dressler syndrome. Late pericarditis is autoimmune in nature. So we're going to call it as Dressler syndrome. And remember, late pericarditis will have other associated features. In exam, they will clearly give that the patient will have fever, high CRP, high ESR, okay, because it's autoimmune and patients will have associated large pericardial effusions, not small, large pericardial effusions, and patients will have arthritis, and patients can have even pleural effusions in even left lower lobe consolidation. That's because of large pericardial effusion that can cause a collapse of the left lower lobe, small portion, basal portion. Okay, that's possible. Left lower lobe collapse or consolidation. And they can have large pleural effusions also. So these are all signs of Dressler syndrome. But see, these signs can occur in early pericarditis also in some pain. That is why the timing is the one that's going to be more important. The timing is the one that's going to be more important. Okay, so here look at the timing. He developed 4 days after a STEMI. So it must be early pericarditis. It's not Dressler syndrome. Dressler syndrome occurs later. And what's the treatment for any pericarditis? Okay, any pericarditis treatment is aspirin. Just increase the dose of aspirin. So usually what is the dose you're going to give? Initial 300 mg during ACS. Then after that 75 mg per day in India. But here you are going to give 650 mg 4 times a day. That's why just increase the dose of aspirin. That itself is enough. Remember, in the first 1 week, NSAIDs are absolutely contraindicated. Routinely pericarditis, you treat with NSAIDs, no problem. First choice itself is NSAIDs only, like Brufen, or probably you can use aceclofenac or whatever NSAID you want. But remember, in first week of MI, NSAIDs are absolutely contraindicated. You cannot use. Maybe in late pericarditis, you can use NSAIDs, but it's not required. Aspirin itself is more than enough. Other NSAIDs are not required. What are the role of steroids? Steroids are not required at all. Even steroids are contraindicated in the first week of MI. In late pericarditis, you can use steroids if it's severe, but most of the times aspirin is enough. No need of anything else. So that's late pericarditis. Okay, so that's done. So then this is a question that you should be able to answer because this is something that we have discussed already. A patient had an MI in the past. Okay, lab values LDL 127. Okay, HDL 32, triglyceride 270. Which of the following must be his treatment plan after MI? So what will you use? So which means patient had a MI, ASCVD, atherosclerotic cardiovascular disease, which means here the goal is secondary prevention. Here the goal is secondary prevention. Because the goal is secondary prevention, you need to use a high intensity statin. High intensity statin. You have to use high intensity statin without a doubt. So what are the high intensity statin? Atorvastatin at 40 to 80 and rosuvastatin at 20 to 40. So the right answer is option C, atorvastatin 80 mg. So you need not add fenofibrate at 162 or 105, whatever dose it is, because this should be done only if the triglyceride levels are more than 500. Otherwise, I'm not going to add fenofibrate. Only if the triglyceride levels are more than 500, you can add fenofibrate. Otherwise, there is no need to add fenofibrate. So option A, B, both are wrong. Because even though this is also high intensity statin, this is also high intensity statin, according to guidelines, only if triglycerides are more than 500, you're going to add fenofibrate. Otherwise, no. The right answer is atorvastatin. Remember, if the triglycerides are less than 500, the first choice for reducing the triglycerides is also statins only. Rosuvastatin 10 milligram is not correct because it's not a high intensity statin. 20 to 40 Rosuvastatin is a high intensity statin. 5 to 10 is moderate intensity only. So right answer is option C for this. This is done. Easy one. Coming to question 16. A 70-year-old man presented with chest pain in order to have 2 mm of ST segment elevation inferior leads. His systolic BP is 84 millimeters of mercury. And heart rate is 124 beats per minute. On examination, he seems less alert, which means he's little drowsy, JVP is elevated, and lungs are clear. Which of the following is best treatment? First of all, this patient is having STEMI, an inferior STEMI. Inferior STEMI, right? So, inferior STEMI. This class will be available, don't worry. So, inferior STEMI, and this patient is presenting with cardiogenic shock. Cardiogenic shock. Patient is having a cardiogenic shock. So, what are you going to do? So, inferior STEMI, cardiogenic shock. There is a high possibility of patient having a right ventricular MI. If you are suspecting a right ventricular MI, what is the first choice? It is IV normal saline. That's the first choice. IV normal saline. So remember, right ventricular MI, I told you it's a preload sensitive condition. You cannot use anything that reduces the preload. Obviously, NTG cannot be used in any shock for that matters. IV dobutamine, no, because patient is in shock. Look at patient is in shock. Shock. Dobutamine is a vasodilating inotrope. Okay, it's going to further, yes, it's going to further reduce the blood pressure. So don't use in shock. Metoprolol, obviously negative inotropic drug, so I'm not going to use. Inferior MI, bradycardia should be present. It depends. It may be present or may not be present. Not always. How many cases of bradycardia you see with inferior MI? You see a sizable number of cases, but not all. In fact, many cases will be without bradycardia. Bradycardia is not the norm in inferior MI. Okay. So, how will you know? So, I mean, in a patient. So, for example, so shock in MI. So, how will you treat? So, that's a very important question, right? Shock in a myocardial infarction. So, it could be due to many causes. The most important reason is pump failure. So, number one is pump failure. Number two is mechanical complications. Number three may be due to arrhythmia. Arrhythmia. Three reasons. This is the usual reason for shock in a patient with MI. So, most important is pump failure. Pump failure could be a left ventricular pump failure or right ventricular pump failure. So, what will be the findings in left ventricular pump failure? Which artery is the culprit artery and what will be the ECG finding? So, generally you will have an anterior MI, elevations in V1, V2, V3, V4 and all. And usual culprit vessel will be left anterior descending artery. And what will be the most important sign? Because it's a left ventricular failure, the pulmonary capillary wedge pressure will be increased. Okay. And the patients are going to have crepitations. Okay. JVP is variable, but crepitations will be there usually. In fact, frank pulmonary edema can be there in most patients. What about right ventricular failure? Usually you will expect in an inferior MI. More importantly, RVMI, right ventricular MI, is the one that's going to produce right ventricular failure. And very commonly RVMI will be having associated inferior MI. Because inferior wall is supplied by PDA. Most of the times, posterior descending artery is going to originate from right coronary artery. So that's why the culprit usually will be RCA. RCA occlusions will usually produce RVMI depending on the level of occlusion, and many times RCA occlusions will have associated inferior MI also, because PDA, posterior descending artery, that supplies the inferior wall of left ventricle, is going to originate from right coronary artery only. What about PCWP? It's a true RVMI only. PCWP will be normal only or even decreased because of right ventricular failure. Why? Because PCWP is a marker of left atrial pressure. And patients will not have crepitations. The patients will have clear chest only. Okay, no crepitations whatsoever because it's a RV failure. Blood is not even moving into the pulmonary circulation. How can I get crepitations in the first place? Clear chest. That's what is exactly occurring. And many patients will have associated elevated JVP because it's a RV failure. So the blood will backflow into right atrium and right atrial pressure will be high, and that is going to increase the CVP and JVP. So that's what is exactly happening. Patient is having inferior STEMI, patient is having hypotension shock, patient is having a clear chest, and patient is having an elevated JVP. All this points towards a RVMI. So what are you going to do in left ventricular failure? In left ventricular failure, the treatment will be inotropes. Inotropes, more importantly. So what inotropes use? Because the patient is in shock. Remember, if the patient is in shock, you need to use non-vasodilating inotropes. What are non-vasodilating inotropes? Dopamine and noradrenaline. So you're going to use dopamine and noradrenaline. You should not use vasodilating inotropes like dobutamine or milrinone if the patient is in shock. That will worsen the shock. That's what we're going to use. So remember here, I will not be able to reduce the preload also. So I can try reducing the preload, plus or minus. I can try reducing the preload. How can I reduce the preload? Preload can be reduced in case if the patient is having a normal BP, NTG, or I can give Lasix, furosemide, diuretics. Okay, epinephrine adults we generally avoid. Adult pediatric population generally, like pediatric practitioners use epinephrine, but in adults we generally avoid epinephrine because it's highly arrhythmogenic. So not NTG or furosemide. So remember, only when the BP is stabilized, you have to use NTG or furosemide. If the BP is low, I cannot use. Remember, NTG and furosemide are again contraindicated in shock. Only when the BP is stabilized with noradrenaline and dopamine, then probably I can, if the patient is having pulmonary edema, to reduce the blood flow to the lungs, to reduce the congestion of the lungs, I can use NTG and furosemide because NTG is a venodilator. Furosemide is also going to reduce the preload. That's optional, okay, only later on, not now. But another option, what they will ask is, you can use IABP, that is intra-aortic balloon counterpulsation. This is something that can be tried as a transient technique. So this is usually used for patients with left ventricular failure and having a cardiogenic shock. IABP is a good option because IABP can per se increase the cardiac output. That is intra-aortic balloon counterpulsation. This is a temporary measure. But remember, in any shock in MI, the best treatment is what? Reperfusion. You have to do PCI or thrombolysis immediately. So reperfusion is the best technique because the cause is ischemia. You reverse it. That's the best treatment. But temporarily you can try these techniques like inotropes and IABP if you have that in your exam. Hydralazine can be given for preload. No, hydralazine is a pure arteriolar vasodilator. Remember, nitroprusside, okay, is an arteriolar vasodilator. They reduce afterload. Hydralazine is also an arteriolar vasodilator. So that also is going to reduce the afterload, not the preload predominantly. And remember, pure afterload reducing drugs like nitroprusside and hydralazine are contraindicated in patients with coronary artery disease. Especially in MI and all, you should never touch nitroprusside. You should never touch hydralazine even if the patient is presenting with high BP. Because these drugs can dilate the arterioles and they can cause steal phenomenon like adenosine. That's why any drug that's a pure arteriolar vasodilator, don't use. Don't use in MI or any ischemic conditions. So what about here? So in right ventricular failure, treatment will be IV fluids. I told you the target JVP will be 10 to 14. Plus or minus, if you want to use, you can use inotropes. Remember, inotropes will not work that much in the setting of RVMI because right ventricle will not be inotrope sensitive. They will be preload sensitive, but they will be inotrope sensitive. But definitely you should avoid reducing preload. Reducing preload is contraindicated because RV is preload sensitive and you cannot reduce the preload. So NTG, Lasix and all should definitely be avoided because RV is preload sensitive. As per the Frank-Starling law, if you give more fluids, it's going to enter the right ventricle and it's going to increase the contractility of the RV. So because somebody is asking how IV fluid works in RVMI, because of the preload sensitivity of right ventricle. It will stretch the right ventricle and Frank-Starling law is going to push the right ventricle to produce more contractility. Mechanical complications different. IABP will not be that effective in RVMI. You cannot use. So mechanical complications means we are talking about acute MR, acute ventricular septal rupture. I don't have time, so I'm not going to discuss all these things. You can discuss later on. And ventricular free wall rupture. 3 acute MR, acute ventricular septal rupture and ventricular free wall rupture. Arrhythmia can be tachyarrhythmias, commonly ventricular tachycardia or VFib, and it could be bradyarrhythmias. Bradyarrhythmias are most commonly associated with inferior MI, especially with RC occlusions. RC occlusions, you get bradyarrhythmias commonly. It could be Mobitz 1, Mobitz 2, sinus bradycardia or even a complete heart block. That's all. So right answer for this is option A. Next question. A 68-year-old gentleman is brought to the ER after a syncope. The monitor showed a heart rate of 190 beats per minute with a BP of 85/50, which means the patient is in shock basically. SpO2 is 98. ECG shows a regular white complex tachycardia with no apparent P waves. With regards to the JVP waveform, which of the following would you expect to see? which are the waveforms you would expect to see? Giant V waves, Cannon A waves, prominent X descent, and slow Y descent. What are you going to see in this patient? See, if I ask you the treatment, what will you say? So look at the history, and if I ask you the treatment, what will be the next step? Very simple. Patient is having a tachy and patient is in shock. So definitely the next treatment will be synchronized DCC. If I ask you the treatment, straightforward, it's a synchronized DCC. So basically, so what are the differential diagnosis of wide complex tachycardia? So when you speak about wide complex tachycardia, so you have only two differentials. One is ventricular tachycardia, second is SVT with aberrancy, which means anything apart from VT is a SVT. SVT with aberrancy. SVT with aberrancy. So if it's regular, what are the differential diagnoses? Regular means it could be a monomorphic VT or it could be a regular SVT with aberrancy. Regular SVT with aberrancy. For example, it could be even a sinus tachycardia. So if it's irregular, you're going to think about polymorphic VT or irregular supraventricular tachycardias like atrial fibrillation with aberrancy. With aberrancy. Okay, that's all. Polymorphic VT will be irregular. Monomorphic VT will be regular. So, what are the, how will you further classify? So, monomorphic VT will not have any apparent P waves generally. What about regular SVT with aberrancy? So, it could be just a sinus tachycardia with probably a bundle branch block, or it could be a atrial tachycardia with a bundle branch block, or it could be a AVNRT, AV nodal reentrant tachycardia with a bundle branch block, or it could be a AVRT with orthodromic conduction. Sorry, AVRT with antidromic conduction, because orthodromic conduction will have a narrow complex tachycardia. AVRT with antidromic conduction. So it could be AVNRT with a bundle branch block, or a sinus tachycardia with some bundle branch block, or atrial tachycardia with bundle branch block, or a AVRT with antidromic conduction. As I told you already, that will have a wide complex tachycardia only. Orthodromic conduction will have narrow complex. So in that we know sinus tachycardia and atrial tachycardia with bundle branch block will have P wave. This is going to have P wave, definitely. In sinus tachycardia, normal P wave. Atrial tachycardia, abnormal P wave. Different morphology. Here, AVNRT and AVRT with antidromic conduction, the P waves will be there but invisible. Most of the times, P waves will not be there at its usual location. So here they have clearly mentioned that the patient is having a regular wide complex tachycardia with no apparent P waves. No apparent P waves. Which means we are dealing with either a monomorphic VT, or we are dealing with the AVNRT with bundle branch block, or we are dealing with the AVRT with antidromic conduction. In all these three conditions, P waves can be hidden and invisible. So in all these three conditions, you are going to see Cannon A waves. You are going to see Cannon A waves. But in monomorphic VT, there will be AV dissociation. In VT, there will be AV dissociation. What is aberrancy? Aberrancy means it could be either a bundle branch block, conduction aberrancy, bundle branch block, or it could be a bypass tract like Wolff-Parkinson-White. That is what we call as aberrancy. So AV dissociation. In AV dissociation, you will see Cannon A waves. Definitely Cannon A waves are a very characteristic feature of AV dissociation. And what type of Cannon A waves? You are going to see irregular Cannon A waves. Irregular Cannon A waves. Whereas in SVTs like AVNRT and AVRT, you will also see Cannon A waves here, but it will be regular Cannon A waves. Regular Cannon A waves. So ultimately, whatever may be the diagnosis, MMVT or here it's regular SVT, the aberrancy with AVNRT or AVRT, the answer is Cannon A waves. So if it's specifically we are thinking about VT, then it will be irregular Cannon A waves. If you're dealing with a SVT with aberrancy, like AVNRT with bundle branch block or AVRT with antidromic conduction, you're going to deal with the regular Cannon A waves. So if it's a VT, it will be irregular Cannon A waves. SVT, regular Cannon A waves. Where you see giant V waves in exam, always think about tricuspid regurgitation. Even constrictive pericarditis can produce giant V waves, but TR is the most important. TR is the most important. Okay? Giant V waves or large V waves. And what about prominent X descent? We know tamponade. We have discussed so many times in our previous lectures. Tamponade, because tamponade, pay tax. Constrictive pericarditis will have deep Y descent and cardiac tamponade will have deep X descent. What about slow Y descent? Slow Y descent will be seen in tricuspid stenosis and tamponade. 2 T's. Slow Y descent. Deep Y descent will be seen in constrictive pericarditis. Prominent Y descent will be seen in constrictive pericarditis. This is called as Friedrich sign. I think we have discussed in one of our previous YouTube sessions, so I'm not going to discuss now. That's called Friedrich sign. Coming to question 18, I'll try to finish off faster, but this is not a tough question, but little tricky question. Which of the following fits into the picture of papillary muscle rupture, cardiac tamponade, VSD and RV infarction in order? So which means I've given 4 cardiac cath data, 4 cardiac catheterization data, and you want to put it in order. So first should be papillary muscle rupture, cardiac tamponade, and third should be VSD, and fourth should be RV infarction. So what happens in papillary muscle rupture? In papillary muscle rupture, you're going to result in MR, acute MR, mitral regurgitation. So whenever there is a mitral regurgitation, your PCWP will be very, very, very high. The pulmonary capillary wedge pressure will be very high. Among all these conditions, which is having very high pulmonary capillary wedge pressure? Because pulmonary capillary wedge pressure is an indirect marker of left atrial pressure. Whenever there is an MR, the jet of MR will go and impinge on the left atrium, and that's going to increase the left atrial pressure. That is going to indirectly cause raised pulmonary capillary wedge pressure. So which is having very high pulmonary capillary wedge pressure? You can see option D is having very high pulmonary capillary wedge pressure, and because of MR, the patient will be in shock. That's why the cardiac index is also very, very low. Okay, so that's why option D. Okay, this is option D. Papillary muscle rupture. What about cardiac tamponade? See, any pericardial disorder, it could be cardiac tamponade or constrictive pericarditis. The number one point that you need to know is there will be increased pressures. Okay, increased diastolic pressures. The diastolic pressures will be increased. Okay, the diastolic pressures will be increased, plus there will be equalization. The chamber pressures will be equal because the fluid around the heart or the pericardial problem like constrictive pericarditis around the heart is going to constrict on the heart, or the tamponade effect will be on all the 4 chambers equally. So that's why pressures will be increased because of compression on the heart, but there will be equalization. So which is the option that is showing that? So look at diastolic pressure, look at right atrial pressure, 21. Look at RV diastolic pressure, 22 in option A. Look at pulmonary capillary wedge pressure, that's 20. Okay, that's also increased because I told you PCWP normal is less than 12. It's more than 12 here. So what happens in cardiac tamponade? The right atrial pressure or the CVP will be equivalent to right ventricular diastolic pressure or right ventricular end diastolic pressure will be equivalent to the left ventricular end diastolic pressure will be equivalent to pulmonary capillary wedge pressure, which is nothing but indirect marker of left atrial pressure. So right atrial pressure, left atrial pressure, right ventricular diastolic pressure, left ventricular diastolic pressure, all these things will be equal and they will be increased also. So you can clearly see that the pressures are equal only in option A. So RAP is increased. Normal CVP is only 6 millimeters of mercury. It's 21 here. It's increased. And RV endostolic pressure is somewhere around like 10 to 15 only. It's increased here. And PCWP normal is less than 12. It's increased here. But you can see all are almost equal. So that's why option A is one corresponds to cardiac tamponade. And what about your VSD? What happens in VSD? So generally whenever there is a defect, so this is a very common thing that you may need to know. So you have the tricuspid valve, and let us assume what happens in ASD and VSD. So let us assume this is the ASD case and the same patient is having a VSD also. So this is right atrium, left atrium, right ventricle, left ventricle, pulmonary artery, aorta. Suppose, what normally happens? The blood comes into right atrium, then into right ventricle, then into pulmonary artery. So what will be the saturation? The pulmonary artery, whatever may be the saturation. Here the saturation will be 75%, here also it will be 75%, here also it will be 75% because it's a venous blood, desaturated blood. Suppose if there is a ASD and there is a blood that is mixing in the right atrium. So this oxygenated blood is going to increase the saturation. Increase the saturation from 75% to maybe even 80 or 90% if it's a ASD. So in right atrium you will see step up of saturation. Similarly, if there is a VSD, you will see step up in saturation. That increased saturation will be seen in the right ventricle. If it's a PDA, if it's a patent ductus arteriosus, then this step up in saturation will be seen in the pulmonary artery level. But in all the 3 conditions, there will be increase in saturation in the pulmonary artery blood. So that's going to tell you whether it's a ASD or, that's not going to tell you ASD or VSD or PDA. But in all three, ASD, VSD as well as PDA, in the final pulmonary artery blood, the saturation will be high. Okay, pulmonary artery saturation will be high. But if the step up typically happens in right atrium, it is ASD. If it occurs in the right ventricle, not in the atrium, then it is VSD. If RA and RV saturation are low, only the pulmonary artery saturation is increased, that's a PDA. So if it's a VSD, okay, then there must be a step up in the pulmonary artery saturation. So look at the pulmonary artery saturation. Out of these four options, which is the option that has a step up in the pulmonary artery saturation? Which means sudden increase in pulmonary artery saturation, where you are seeing in option B. So that tells you it is a VSD. So option option B must be VSD. So RV infarction. So we already know if it's going to be right ventricular infarction, you're going to have acute right ventricular failure. So look at this, where your CVP is very high. So look at option C here. The right atrial pressure is very high, so which means the CVP is very high, and the PCWP is almost normal. We discussed in the previous question only. I think just before that we discussed. I told you in right ventricular MI, PCWP will be normal, but JVP will be increased. We discussed just a while ago. That's what is happening. The CVP is high, more than 6 is normal, so definitely more than 6, and PCWP is normal, less than 12. So increased right atrial pressure with a normal PCWP means it must be RV infarction. So option C is the one that fits into RV infarction. So the right answer is DABC. This is a tough question, but it incorporates a lot of concepts in that. So papillary muscle rupture fits into D, cardiac tamponade fits into A, and VSD fits into B, and RV infarction fits into C. Okay. Now coming to question number 19. Which among the following, according to latest guidelines, is not an indication to infect endocarditis prophylaxis? This is some common question that's been asked in the recent 2-3 exams. Very commonly they're asking this again and again and again. So I told you there are only 6 indications. Maybe in case 5 indications for infect endocarditis prophylaxis. Yes, that's actually kind of tough question, but it should have some tough questions, isn't it, Dr. Amelia? You should not have all easy questions so that you can answer everything so easily. But that one question will tell you so much of hemodynamics. You can understand everything with that. Maybe you can repeat the video again, or you can see the video again one more time so that you will be able to comprehend that better. But anyway, fine. So what about the 5 important indications? I told you number 1 is prior infected endocarditis, very commonly asked. Second is presence of prosthetic valves. Presence of prosthetic valves. Okay, number 3, cardiac transplant with valvulopathy. Cardiac transplant with valvulopathy. Number 4, cardiac transplant with valvulopathy. Number 4 is going to be unrepaired cyanotic congenital heart disease. Unrepaired cyanotic congenital heart disease. Number 5, repaired cyanotic congenital heart disease. Repaired congenital heart disease. Any congenital heart disease doesn't matter. Repaired, but if there is any ongoing leak, which means the repair is defective, or if the patient has some prosthetic material. Dr. Amelia is asking whether that question will come in NEET PG or not. Honestly speaking, that was a question in 2016 and not exactly the same. So they asked like the cardiac tamponade they asked already in INA CT twice, and in NEET PG in 2017 and 18. They asked papillary muscle rupture and MR both in NEET PG already, and they have asked VSD step up in saturation also in one of the INA CT and NEET PG exams in 2016 and 17. Only thing they have not asked in this question so far is RV infarction. Everything else they have asked already. Okay. So coming back to that, 5th one is repaired congenital heart disease. Any congenital heart disease, cyanotic or acyanotic, doesn't matter. If there is an ongoing leak or if there is a prosthetic material, but in this first 6 months only you need prophylaxis. Okay. After that it's not required. So option A, prior IE, indication. Unrepaired cyanotic congenital heart disease, indication. Cardiac transplant with valvulopathy, indication. MVP with severe MR is not in the guideline. So that's the right answer. The right answer is option B for this question. And for what procedures you give? Only for 2 procedures. One is dental procedures, including root canal treatment. Number 2 will be respiratory procedures or invasive respiratory tract procedures like bronchoscopic biopsy. Invasive respiratory tract procedures. Only for these two procedures, prior to these procedures, you have to give. Other procedures, no. Only two procedures, dental and invasive respiratory tract procedures. And what antibiotics you will use? You can use either amoxicillin or ampicillin according to the guidelines. Or if the patient is allergic to penicillin, then you can use clindamycin because it's available both oral and IV. Amoxicillin is an oral drug, ampicillin is IV drug, and clindamycin is available both oral as well as IV. Ultimately, when you will give single dose, just one dose is enough, one shot of drug, one dose, 1 gram of ampicillin or amoxicillin or 600 milligram of clindamycin, just one dose, once 30 to 60 minutes prior to procedure. 30 to 60 minutes prior to procedure. That's it. Nothing more than that is required. This is the prophylaxis for infected endocarditis. So prophylaxis is very, very important. That's the very high yielding area. If at all they ask something about infected endocarditis, they're going to ask that only. Final question. A 68-year-old man with a past medical history of coronary artery disease develops a myocardial infarction. He got treated in CCU before he's getting discharged, undergoes echocardiography, which reveals a LV ejection fraction of 35 to 40%. He is completely asymptomatic. Repeat echo after 3 months shows the same findings. What is the patient's heart failure stage? This is based on ACCHA heart failure stage. NIHA is very important. You know, NIHA is a functional status. NIHA is a functional status. It's totally based on patient's functional capacity and patient's symptoms. NIHA class 1 means patient is totally asymptomatic with usual activities. NIHA class 2 means the patient will be symptomatic with ordinary activities. With usual and ordinary activities, patient will be symptomatic. So which means he's not able to do his usual and ordinary activities. That is NIHA class 2. NIHA class 3 means patient is symptomatic with less than usual or ordinary activities. Which means even patient will not be able to go to the kitchen and take water and drink, go to the bathroom and pee and come, go to the bathroom and bath. So do like the standard like homekeeping work and also. Even if they can't do that, that is NIHA class 3. NIHA class 4 means patient is symptomatic at rest itself. Which means they cannot do anything without dyspnea. They will be completely bedridden. In the sense, if they start walking also, they'll get dyspnea. That is NIHA class 4. Symptomatic at rest, or they cannot do anything without dyspnea. That is class 4. So it is the most powerful. NIHA is the most powerful prognostic system. It's the most powerful prognostic system for heart failure. In heart failure, it is the most powerful prognostic system as far as the heart failure therapies are concerned. There is nothing else more powerful than NIHA. That's why they always ask about NIHA. It can be used only for patients with heart failure though. And the idea of all the therapies that you use in heart failure is to keep the patient in NIHA class 1. Remember, the moment you call it as a chronic heart failure, it is irreversible. Any chronic disease is irreversible. You cannot change it. So our idea is to keep the patient in NIHA class 1. Whatever therapies you are using, the idea is very simple. You have to maintain the patient in NIHA class 1. It's all about NIHA. What about ACCHA staging? Heart failure staging. Heart failure staging is different. In stage 1, patient will have only risk factors. Patient is not having structural heart disease. Patient is not having any symptoms also. Asymptomatic, and patient is not having any structural problem also. Structural disease in the heart. Echo is normal. Imaging will be normal. Class 2, patient will have structural problem. Structural heart disease. Imaging can pick up some structural heart disease, but the patient will be asymptomatic. That is class 2. Class 3, patient becomes symptomatic. Once the patient is having symptoms, it is class 3. Class 4 means patient will have refractory heart failure, which means your usual therapies are not working. Refractory heart failure, usual therapies are not working. So most of the patients will actually present to us in class 3. In India, in developing countries like India, most of the patients are going to present in class 3, stage 3 only, where the patient will be symptomatic and obviously echo will show some abnormality. So the right answer for this question is option B. Why option B? Stage B, because patient here is asymptomatic, but he is having structural heart disease, low ejection fraction. So asymptomatic and having a structural heart problem is actually class 2. So that's why the right answer for this question is class 2. Okay. So then how will you treat the patients? I mean, first of all, how will you classify patients? So technically, whenever you have a patient with heart failure, we are going to divide based on the ejection fraction. If the EF is less than or equal to 40 percentage, or maybe you can say less than 40 percentage, it is heart failure with reduced ejection fraction. If the EF is in the range of 41 to 49 percentage, it is heart failure with mildly reduced ejection fraction. Previously, they used to call this as mid-range ejection fraction, but many guidelines have changed the notion. It's called mildly reduced ejection fraction. And EF more than or equal to 50%, it's called as heart failure with preserved ejection fraction. So remember, whatever therapies that we are talking about is all warranted for heart failure with reduced ejection fraction. None of the therapies has been proven to be effective for heart failure with preserved ejection fraction. In mildly reduced ejection fraction, some therapies may work and some therapies may not work. It's somewhere in between. But none of the therapies that we use for HFrEF is going to work for HFpF. In fact, we don't know what is the exact treatment for HFpF as of now. And in exam, they might ask about what is the difference between HFrEF and HFpF in community. That's one of the INACT questions. HFrEF patients tend to die because of cardiovascular death. So remember, 85% of death is due to cardiovascular death in HFrEF. 15% of death will be due to non-CV death. 15% will be non-CV death. This is the data. So which means 85% of the patients is going to die because of arrhythmias that causes sudden death. So CV death means two types. Sudden death, death within 1 hour of onset of symptoms. That's sudden death. Usually it will be due to arrhythmia. Second, death may be due to progressive heart failure. That's the second reason for cardiovascular death. But non-CV death means it could be anything. It could be due to infections. It could be due to withdrawal from care. It could be due to suicide. It could be due to something else like accident, RTS. So many things are there that will come under non-CV death. But remember, in HFpF, 60% still will die because of cardiovascular death only. 40% will die because of non-CV death. 40% will die because of non-CV death. If it's HFpF. So what the exam question asked in 2021 to be precise, is HFpF patients tend to have higher proportion of non-CV death. That's correct. Even though the most common cause of death in HFpF patients is also still cardiovascular death only, there are more patients who are dying out of non-CV death in HFpF compared to HFrEF. And overall mortality, if you look at the overall mortality between HFrEF and HFpF is similar, which means there is no change. Similar. Both of them die. But the problem is, I would say HFpF is more problematic than HFrEF because we don't have any effective treatment also. Even though RNAs have been tried, spironolactone have been tried, only in certain subsets it's been effective, but basically it's not thought to be that effective. So what are the first line? What are the drugs that improve survival? Okay, in patients with HFrEF. We are talking only about HFrEF, not about HFpF. Number one, RNA, very powerful drugs. These are the first line drugs as of now. Alternative to them is either you can use ACE inhibitors or you can use ARBs. Number two, beta blockers. The three beta blockers: metoprolol, bisoprolol, carvedilol. Number three, MRS, mineralocorticoid receptor antagonists like spironolactone and eplerenone. We know that. Number four, interestingly, SGLT2 inhibitors. Very important. They improve survival. Number five, HISDN combination. This is proven only in black population in US. Even in India, we commonly use this drug, but only in black population, survival has been proven, improvement in survival. Otherwise, it's not proven in other population. Okay. Number six, certain interventions have been proven to improve survival. Interventions have been proven to improve survival. What are the two interventions? One is CRT, that is cardiac resynchronization therapy, and second one is going to be ICD implantation. But you have to select the patients appropriately. So who are the patients who will be eligible for CRT? So those who are in NIHA class 2 to 4, okay, plus they should have a white QRS in ECG. At least more than 120 milliseconds, but if it's more than 150 milliseconds, it's best. What about ICD? ICD. Okay. ICD will be indicated in patients with NIHA class 2-3. Okay, NIHA class 2-3, not NIHA class 4 though, because of various reasons. Okay, and of course, all of these patients should have an ejection fraction of less than 35%. NIHA class 2-3 plus having a ejection fraction of less than or equal to 35%. This is for primary prevention. So because the usual reason for death in patients with heart failure is ventricular arrhythmias, and that can be prevented with ICD. CRT is also called as biventricular pacing. The other name for CRT is biventricular pacing, where you're going to pace both the right ventricle and the left ventricle together. That's called biventricular pacing. So dual chambered pacing is different. Dual chambered means you are pacing both RA and RV. That is dual chambered pacing. We are talking biventricular pacing. That's the correct name. So NIHA class 2-3 with white QRS and EF of less than or equal to 35%. So this is the indication. ICD NIHA class 2-3 with EF of 35%. These are primary indications. These can, in selected in this group of patients, it can improve survival overall. What are the drugs that have no improvement in survival? No change in survival. No change in survival. Number one, any diuretic. Diuretic agent, no change in survival. Remember, diuretic agents are considered to be class 1 drugs in heart failure treatment. If congestion is there, definitely you can use. If congestion is there, please use. Please use diuretics, because diuretics can reduce the heart failure hospitalization. In fact, it's a class 1 drug in heart failure. If there is a congestion, 100% you can use, no doubt. Please use, but it doesn't alter survival. Number two, any CCB. We don't use CCBs at all. No change in survival. And digoxin. Dig has no change in survival. Number four, ivabradine. No improvement in survival. Even though we use for symptomatic relief, no change in survival. Survival has not been proven. Improvement in survival. Number five, we have some more things, right? So what are the things we use that commonly? Yeah, newer drug, vericiguat. It's a soluble guanide cyclase activator, vericiguat. Not proven to improve survival, but improve symptoms. Vericiguat. It's a soluble guanide cyclase activator like riociguat. Riociguat is used in pulmonary artery hypertension. Vericiguat is used in heart failure. Both are basically soluble guanide cyclase activators only. And okay, what I mean, people are commenting. Oh, cardiac transplant. Cardiac transplant is an advanced heart failure treatment. For refractory heart failure, we can use cardiac transplant as an option, but not here. So that's a final treatment. So any chronic disease ultimately will end up with a transplant. Otherwise, patient is going to die. But how fast they end up with a transplant depends on a lot of underlying comorbid conditions and how well they maintain the disease after that. So vericiguat. Vericiguat is something that's not going to improve survival. Ivabradine is not going to improve survival. Dig is not going to improve survival. CCBs are not going to improve survival. Diuretics are not going to improve survival. Another group of drug I forgot to say, that is SGLT2 inhibitor. I told you, correct. I told you, I thought I forgot. SGLT2 inhibitors are there. So these are the drugs that have no improvement in survival. Or inotrope infusions like milrinone infusion or amrinone infusion. So whatever inotrope infusions you're going to use, that's not going to improve survival. And they've tried so many other drugs like nesiritin. What is nesiritin? That's a recombinant BNP. Even that has not been shown to improve survival even in patients with acute heart failure. So plenty of drugs are there that does no change in survival or no improvement in survival. So these drugs should be used only when the patient is having severe symptoms despite using all the first line drugs and interventions. Then only have to use this, otherwise don't use. And even nitrates alone, interestingly, nitrates alone doesn't have improvement in survival. Nitrates alone without hydrolyzin component. Even if you're using with hydrolyzin component, you have to use in blacks. Then only your survival benefit will be there according to the research. So in non-blacks, no survival benefit. Similarly, nitrates alone or even hydrolyzin alone doesn't have any survival benefit. Only combination of hydrolyzin and ISDN has survival benefit that has been proven only in black population. That's it. So these are the first line drugs you have to use along with diuretics in case if the patient is having congestion. Okay. Now, what about refractory heart failure? If the patient is having refractory symptoms, if the patient is having refractory heart failure, then two treatment options are there. One is your LVAD, VAD devices, left ventricular assist device. Second is cardiac transplant. That's it. Cardiac transplantation. Only two options are there for patients with refractory heart failure or advanced stage heart failure. Left ventricular assist device and cardiac transplant. LVAD can be used as a bridge to transplant. Like till the patient is getting a transplant, you can use LVAD device, or probably you can use as a destination therapy. In patients who are not eligible for transplant, this could be the final treatment. So till their death, they can maintain with the LVAD itself. Or you can use this as a bridge to transplant. Till the patient is getting a transplant, you can maintain the patient and maintain their life with left ventricular assist devices. Final treatment is cardiac transplant. Okay, so that's the ultimate option. But India, in an average in India, the data says that only 200 cardiac transplants are being done, which is much lesser compared to other countries. In US, an estimated 600 to 800 transplants are done per year. In India, as an average, only 200 cardiac transplants has been done, even though that number is increasing in the recent past. So I've given a good overview about heart failure also, and I've tried to give as much as data as possible in this 3-hour revision session of cardiology. So hopefully the questions were easy and at the same time challenging also, provided you have learned a lot of things so that you can now get to know what are the topics that are important for exams. And with this, if you like our channel, please subscribe to our channel. Okay. And let me finish the session. Okay, thank you so much. Revise better, and next week we are going to come up with another session. Okay, till that, stay tuned. Thank you, friends. Next class is next Saturday, obviously. Okay, thank you. Bye bye. See you all. Good night. Bye bye.